Yeah. nuko kumera kabagira nuko makuru ingaserutse ngana mutaranye mwirirwa ntaro nuko amameza amakuru y'igiti bajya kugira imana ahubwo rero ehe nuko amameza bajya kugira imana nuko mama bazi urugamba rw'umwe rukarema ehe ahubwo rero yego nuko baba bakuyoretse bagira ehe ehe isenga rya ahubwo rero ehe nuko abagore n'igiti bajya kugira imana ahubwo rero Eh. Rwanda kubitanukana abanyabasende bakanye simande gisenya muga.
A round of applause, please, for them.
That's a glimpse in the
We have those who are from Denmark. We are so privileged to have you here.
Welcome. Fantastic.
We have Geneva here. You are very welcome. You can tell from my voice. Please rise up, Geneva. We want to celebrate you.
Welcome, welcome, welcome. Wonderful.
We have Switzerland represented. Please rise up. Someone logging in online. Celebrate them. Keep celebrating.
This is wonderful.
And we have every one of you that is here. Did I mention Ghana? Ghana is here.
Welcome. Welcome.
You normally save the best for the last.
All right.
We love you and thank you for making it to this place.
And for people who like using social media, don't forget our hashtag is at NCD, hashtag NCD Conference 2022. Let's make the world know what we are doing here, okay? Let's make even the NCDs, wherever they are, that we are fighting them. So the fight is real, okay? Yeah, we have people in the house, and we don't want to take so much of our time. Allow us to start by calling people to give us some opening remarks. We are so much grateful to the NCD Alliance Rwanda. We are going to recognize other alliances that are in the house as time goes on. But at the moment, let's allow people from Rwanda, who are the hosts, to start this for us. I'm going to welcome on stage Professor Joseph Muchumbisi, who is the chairperson of Rwanda NCD Alliance, to give us his opening remarks. Thank you. A round of applause as he comes on stage.
Good morning, everyone. Honorable Minister of State in the Ministry of Health, Dr. Tarcisse Mhunga. Honorable the Director General of IBC, who is represented by the manager of the NCD division, the representative of WHO Rwanda office, our guests from Imbuto Foundation, the Lord Mayor of the city of Kigali, heads of private companies, civil society organizations, and patients group, distinguished guests and participants, ladies and gentlemen. On behalf of the Rwanda NCD Alliance and this NCD Alliance East Africa and the entire organizing committee of this regional NCD Conference 2022, it is my pleasure and a great honor to give you a warm welcome and introduce you this first regional gathering on NCDs. Allow me first to express my gratitude to all the efforts made by different partners to make this conference possible. I would like to recognize the Rwanda Ministry of Health and Rwanda Biomedical Center for their essential contribution together with other actors, leading the journey and guiding us the whole process of planning. I would like also to acknowledge the support from different key partners like WHO, UNICEF Rwanda, Africa Medical Supply, BioSensor, Christian Plan Mission, Medtronic Lab, Partners in Health, Global NCD Alliance, Danish NCD Alliance, and East African NCD Alliance, to mention a few. Of course, the conference couldn't be a success without our high-profile international and national speakers and panelists, and I want to thank you all for your commitment and support. We wanted this conference as a regional gathering to be a distinctive platform that brings together different institutions, academicians, international, regional, and local civil society, and people living in cities, organizations from across the region and beyond. We are so happy to welcome delegates not only from the 6 national alliances, member of East Africa NCD Alliance, but also from NCD alliances from Ethiopia, Senegal, Ghana, Cameroon, and Malawi, as well as the African NCD Network, the Danish NCD Alliance, and Global NCD Alliance. Value very much indeed all our participants from different stakeholders, partners, institutions, and organizations, including people living with NCDs, who are our key advocates. On the program, we propose a wide range of sessions and topics, including WHO Global NCD targets for 2030, the best buy and pen plus strategies, the availability of NCD services, innovations and technology for NCDs, and different best practices. We expect participants to learn, discuss, reflect, share lived experiences, best practices, and come up with recommendations for regional policies, strategies, solutions, and innovations toward people-centered prevention, control, and equitable access to quality care for NCDs in East Africa and beyond. At Rwanda NCD Alliance, we are grateful for such opportunity to be hosting this regional conference for the very first time, and we wish, together with the other members of NCD Alliance, that it can become an event rotating among the East African community countries, and why not in other African countries. Allow me to wish to all participants in the room and virtual rich and fruitful discussions, and to our guests from abroad, wonderful stay in the country of 1,000 hills. Thank you for your kind attention. Welcome to Rwanda. Murakaza neza mu Rwanda. Karibu Rwanda.
Arakoze cyane. Round of applause to Professor Mucumbitsi for the kind welcome remarks. Dr. Mucumbitsi was someone who inspired most of us as we are still in the university to get to this journey of fighting the NCDs. I'm really grateful to that. I have seen around the house also Professor Stephen Risa used to be our dean by then. These are people who gave us a nice push to start the fight against the NCDs. I really like giving credit where it is due. So our next speaker is Professor Jean-Marie Dangu, the WHO Afro NCDs coordinator. So our technicians, let's have the speech from Professor Jean-Marie.
Let the working. I'd like you to lift up one finger, please. Oh, it's ready. Thank you.
Right. As we're waiting for the technicians to give us the speech from Professor Jean-Marie, I think let's go on. The next person I'm going to welcome here is someone who also gave us a very big push when we were still versus Rwanda. He'll be our leading in the fight against the NCDs. You are welcome, Mr. Prudence Rwingisa, the mayor of the city of Kigali. Round of applause as he comes on stage.
Honorable Minister of State in the Ministry of Health, the chairperson of Rwanda NCD Alliance, and president of East African NCD Alliance, ladies and gentlemen, distinguished guests, good morning. Madam Seneza. It's my great pleasure and honor to, first of all, welcome you in the city of Kigali. And also, we are very much delighted, actually, for the NCD Alliance to having chosen to meet in our beautiful city of Kigali. As it has been said, I think we are also on the forefront, joining others as we fight against NCDs and also maintaining good health for our citizens. NCDs have been considered to have the high prevalence rates in urban areas. And this has been attributed to different factors that are related to the city challenges. I can name some. When you look at around us, we see the air pollution consequences of climate change. When you look around, people have probably a kind of indiscipline in feeding themselves or not even having enough means actually for a proper or a decent meal, but also people not exercising enough. And this is really affecting, basically, in most cases, the urban areas. And so this is the case for our city. We've been actually joining our efforts with stakeholders, Rwanda Biomedical Center, the Ministry of Health, and other stakeholders eventually, and particularly also the NCD Alliance that really have been giving us a push and also support as we try our best to fight against NCDs for our residents and citizens in the city. And some of the factors, as I said, are attributed to non-controllable issues, but we can definitely do something as we've started to make sure that when we change, we decided to actually, during the CAF days, trying to avail the services for people to get free tests and also know their conditions and be able to prevent and also, get assistance when need be. We have again reviewed our master plan for the sixth movement, kind of, where we avail different, I would say, neighborhoods with a minimum basic services. Can find a church, can find a school, a health center in a walkable distance, so that we promote that and make sure that people do actually exercise as we fight against the NCDs. We are also continuing with other stakeholders to conduct mass campaign, increasing the awareness, as well as having the regular testing and also approaching the neighbors in a given small village with the support of the ministry that has really tried to provide the services through health workers. And again, that proximity allows us to continue monitoring at every village level the situation. So the screening processes are still going on, and we thank you so much, Honorable Minister. We thank the NCD Alliance for this support. We really feel that not only the citizen feel secured, but also they feel that they get the information at hand on how they can behave and how they can also prevent the NCDs to spread. We thank you again for the training you are offering to our communities through the campaigning, but also we are still again observing that the approach you've taken to decentralize to the very lower level of our neighborhood and get at hand the support, the information. I think every Rwanda now, I mean, the citizens in the city know that the NCDs are an issue. They know that they could also combat that by approaching the services that you have availed at every level of our neighborhood. Honorable Minister, I cannot conclude my remarks without thanking you personally as the Minister of State, but also at your individual level, that your support to the city residents in all, not only in combating NCDs, but in all health-related aspects, has been very supportive to make sure that our residents have better health conditions, and also we continue feeling it and getting your support with other stakeholders. As I conclude, Mr. Ladies and gentlemen, allow me to thank all participants that traveled all the way to have to attend this conference in our beautiful city, and I will invite you when you have free time to get a chance and actually have a look and feel of what Kigali is day, night, and every time that you are still around. Thank you so much.
Big round of applause to the mayor of Kigali City. From his speech, it's evident that everyone is welcome in Rwanda, and particularly in Kigali. And we are safe with his welcome. So now we can proceed. And this moment, ladies and gentlemen, allow me to welcome our guests of honor, who is the Minister of State in charge of primary health care, the Honorable Tarasis Munga, Dr. Tarasis Munga, beg your pardon, to give the official opening remarks at this conference. Honorable Minister, you're welcome.
Subcommittee, the chairperson of East Africa NCD Alliance, Road Mayor of Kigali, President, Head of UN agencies and development partners, Head of international and national NGOs, representative of East Africa Community Member States, Chair of NCD Alliance of East Africa Member States, private sector representative, patient group, distinguished guests, ladies and gentlemen, good morning. I am pleased to welcome you here in Kigali City for this regional NCD conference with a crucial theme of shaping an East Africa free of NCDs through people-centered interventions and transformative development. I thank the East Africa NCD Alliance for choosing Rwanda to host this regional NCD conference. I also take the opportunity to express gratitude to the representative of different organizations, speakers, researchers, and all participants who have come from over the world and across the country to attend this conference. We are pleased to have you here with us today. Allow me to recognize the great work that has been done by the NCD Rwanda Alliance, Rwanda Political Center, and our distinguished partners who organize this important conference. This is an excellent example of what we can achieve if we work together. Distinguished guests, NCD affects all of us. We all know or have lost someone we love to heart disease, cancer, diabetes, or respiratory disease. I am sure some of us in this room may suffer from any disease or any related condition. But maybe I'm wrong. I see most of people here are very young. Every year, an estimated 17 million people die prematurely from NCDs. That is one person every 2 seconds on average. Unfortunately, around 86% of those deaths are in lower and middle income countries, which constitute a threat to our social economy development for our country. In the SDGs, countries have set a target to reduce premature death from communicable disease by 1/3 20. But if you look at the current trend, we are not reaching the target without having dramatic or strategic action and commitment from the leadership. We also require a whole that approach. Everyone has a role to play in this global fight. I am delighted to see such a distinguished group of leaders gathering for 2 days here in Kigali, discussing prevention and control measures which will champion action on NCD nationally and regionally. I am happy also to see the conference also includes mental health and disability, which are also our key priority for our East Africa community. Rwanda is not spared by this pandemic of NCDs. NCDs count for 44% of all deaths in Rwanda. If we add injuries, the mortality rate is 8%. The majority of those deaths are premature. Our people are dying while in this Our people that are dying while in their prime age, which has huge impact, which has a huge negative impact on the development of our continent. So the good news is that we know how to prevent NCDs and we know how to manage them. In fact, a big proportion of the premature death from NCDs can be avoided through cost-effective solutions with a primary health care approach and universal health coverage. Rwanda is taking a bold steps to provide lasting solutions to this growing burden of NCDs. Guided by our national NCD strategy and the cost action plan 2020-2025, we are happy to share some of our achievements that can also be replicated in our region. NCDs awareness, screening, and the follow-up have been included in our package of services for our CHW. They are focusing primarily on promoting aid detection and the timely management. In collaboration with other sectors, we are promoting physical activity through our D-Week Car-Free Day in different cities, which also serve as a platform for NCD awareness and the screening. The Lord Mayor, I think, is the one of the champions of our Car-Free Day. The management of NCD have been decentralized by my health care level at all health centers. We have dedicated NCD clinics run by well-trained nurses, and at all hospitals at district level, they are implementing 10 plus recently adopted by the Afro WHO. Ensure financial accessibility. NCDs care and treatment services are covered by health insurance, including health insurance. That is the NCD treatment centers are being established to allow our people to be treated within our country. So we know that the journey is still long, but we are confident that together with our partners, we reverse the trend of NCDs funding. I'd like also to encourage our countries to integrate NCDs prevention and control into our existing health system with a focus on primary health care as the foundation of universal health coverage. This includes expanding and sustaining access to promotion and disease prevention, management, and control, while addressing social, commercial, and environmental development. As I conclude, I would like once again to express my gratitude to the conference organizers. Hope that today's researchers, policymakers, advocates, and the partners will share ideas and visuals discussing about ongoing challenges in responses in prevention and control and inspire new mediated standards and practices fighting against diseases so that we can improve our beloved people by improving the life of our population across Africa. Now meet the end here by wishing you all an engaging and productive conference. Hope you enjoy relevance. Very meeting in some other places. Rwanda. Again, thank you.
A round of applause. Ladies and gentlemen. Thank you so much, Minister of State. Minister of State, I would like to say that I've personally been following you and I'll continue following you. Thank you for being a very strong advocate on NCDs. Let's celebrate it one more time. Ladies and gentlemen, when we talk about NCDs, it's very important to know and hear from the people that experience the challenge. And I'd like to let you know that we are not here
Media, please
without
mute
a
yourselves.
purpose.
Media, mute.
And I want to see that, ladies and
Please
gentlemen, that are
disable your
involved.
video.
If you're serving or having an NCD, could you please rise up on your feet? We are here to advocate for us. I'm one of them. Please stand up and let's celebrate them. Let's celebrate them. Let's celebrate them. If you have an NCD case, please rise up. I'm one of them. Thank you for celebrating them. It's important to discuss about issues that people are actually facing, and it's very vital that they are here. Thank you, sir, for being a very strong advocate. When I grow up, I want to be like you. I'd like to invite a very strong man, Joseph, to come and speak about what we are talking about. As he comes, could you please tell your neighbor, be attentive. You're very welcome, sir. Let's celebrate him as he's walking majestically, confidently, and he's going to speak to us about what it is. He's sharing a testimony. You're welcome to Rwanda.
Good morning. Bonjour. Mwaramutse neza. Honorable Minister of State in Ministry of Health, Mayor of Kigali City, Eastern delegates, ladies, gentlemen. My name is Joseph Keribuga. I am a Rwandan, 63 years old. I am a retired veterinarian, public health specialist, and with a lived experience of 3 NCDs. I am a stroke survivor, president and the legal representative of Stroke Action Rwanda, a stroke support organization, member of Rwanda Non-Communicable Disease Alliance. I am sharing my story because I wish to recognize the impact of healthcare providers on my NCD journey. I also wish to encourage people living with NCD to share their story, their challenges, their lessons, as this can help to shape a public health narrative that can serve to advocate and raise awareness on NCDs among. But I was thinking that this was due to my demanding work schedule as a lecturer. The doctor advised that I reduce my blood pressure by taking me the weekend to relax, as the job required a good medical certificate. Unfortunately, thinking about the opportunity I could lose caused my blood pressure to rise to alarming levels. Out of goodwill, the physician recorded the previous lower value and wished me luck. Through my new employer, I underwent additional medical exam, which confirmed I had type 2 diabetes and hypertension. Despite landing the job, I was urged to reduce my blood sugar and pressure within 3 months. I achieved this with the help of a physician at the diabetes clinic of the Rwanda Diabetes Association, who advised me and prescribed me medicines in a human and professional way. For the blood pressure, I found a good private cardiologist, which is very expensive for someone paying out of pocket. Luckily, I was covered by medical insurance through my employer. I've been with this cardiologist for 15 years, and our communication is good. He has time for me and is knowledgeable. As I am reading multiple NCD, we still took the role of prescribing medication for both diabetes and hypertension. Stroke occurred unexpectedly at around 4 p.m. on 20th of June 2016. I was I was 57 years old. My wife rushed me to the nearest referral hospital within 1 hour, where a general practitioner gave me an intravenous drip to reduce my blood sugar and pressure. I was then admitted to the general ward of the treatment station, wait for a specialist doctor who was on night duty at another referral hospital. She arrived around 9 a.m. and after examining my case, recommended an MRI exam. Unfortunately, the findings were inconclusive. Confirmation of ischemic stroke with left-sided emplasia was obtained the next day using carotid artery ultrasonography. The physician prescribed cardioaspirin and advised continuing reactive and hypertension medicines. Rehabilitation therapy was also prescribed. This is how I survived the cerebrovascular accident. Upon reflection, I realized that despite difficult working conditions, the healthcare provider saved my life. I am so grateful to them. After a week-long hospital admission, I was discharged to home in a wheelchair. My hospital stay was short because I arrived early within the hours of my stroke symptoms onset. In contrast, my colleague Wisdom, here I am using pseudonym for confidentiality and respect of privacy. My colleague Wisdom had a hemorrhagic stroke and arrived at hospital 24 hours after the onset of symptoms because she was denied access to the only ambulance available at the nearest health center. The source shortage means that the Ministry of Health has made difficult decisions, including limiting ambulances at health centers to transportation of pregnant women to prevent high rates of mother and child mortality. Wisdom was discharged after 3 months of hospital stay and later on had complication of dysphagia. He stays at home in need of palliative care. We were discharged to home with a loss of physical autonomy, lack of trained caregivers without any pre-assessment because there is a shortage of highly trained healthcare providers to effectively provide guidance and support. Physicians recommended physiotherapy without explaining why, where to go, or how long it will take. This transition period can be very difficult. It is like you have to learn the first step of life. So far, it is difficult for colleagues without medical insurance or with community health insurance to pay out of pocket for healthcare services available in the private sector. This is the case for rehabilitation services well equipped in the private and in the pharmacy when there is a stock out in the public health facilities. Yes, each citizen can purchase community health insurance, yet private services are not part of its package. Another colleague I called Halloween, a colleague with type 2 diabetes complication, couldn't afford to pay for his leg amputation before the hospital finally requested the local government authority to pay for it. Due to the barrier identified through these experiences, Cindy and I created a social media group where our colleagues living with NCD could come together and share information on their condition. I later went on to create and lead Stroke Action Rwanda for our community to raise NCD awareness and advocate for proper care of NCD. We cannot wait to change the NCD response. Through my lived experience with multiple NCDs, I learned about the gaps in NCD service delivery and affordability of care and medicines, and the lack of quality rehabilitation service in the community for NCD patients with severe disabilities. I have observed delay in the diagnosis of NCDs condition, which I think is due to insufficient trained healthcare providers and or shortage of specialized NCD clinics. I learned that there is very limited capacity at the community level to raise awareness and to screen for NCD in the population to prevent future complications when a patient presents to the district hospital. I strongly support that all people living with NCD must be able to easily access quality NCD services, which is not the case today in Rwanda. I call upon the Ministry of Health to review the staffing and equipment of the health center to allow them to perform early screening for NCDs and provide basic compensation for NCDs in the community. I also call upon the Ministry of Health to ensure that medicines for NCDs are available in all public health facilities and affordable for all categories of the population. Specifically, for people living with stroke, I call upon the Ministry of Health to establish stroke care units in referral hospitals so that people suffering from stroke do not spend too much time in emergency rooms, as well as disseminating guidelines for acute pre-hospital and in-hospital stroke care across the health system. Moreover, the Ministry of Health should ensure an adequate number of trained health care professionals for stroke treatment and care. Lastly, I call upon the Ministry of Health to promote the creation of well-equipped post-stroke rehabilitation centers in the community. Before I conclude my story, I wish to thank the organizers of this conference, to thank them for the opportunity they gave me to share with this important gathering, share my story in this important gathering. Thank you all.
You You can celebrate him better than that. Thank you very much for sharing your story. From my toning, you can tell that it's a very painful experience. And I would like,
And as strong as he shares this experience, that shows the level of strength that he has, how he shared the experience from day one up to date.
I would like, as you're sitting on that beautiful chair, just tell your neighbor that you have a role to play. Speak to your neighbor. You have a role to play. And if they ask you what role, please tell them, speak about this burden in the world.
You can be a champion in different ways. You can be a champion in speaking up against NCDs. You can be a champion in arranging campaigns. You can be a champion in screening events. You can be a champion different ways. Anything, any way that is really possible for you.
Can I ask all of us to know this is a burden? Could you please lift up one finger? I want you to try. In Africa, when there is a problem, we easily hit our chest. Could you try and hit your chest with that one finger? Can it make anything? Could you please try with two fingers? Try and cause. Is it making any sound? Could you try with a third one, please? Everybody. Can somebody feel you're hitting your chest? Could you try with 4 fingers? Does it do anything? Could you try with a 5 and hit your chest and say, this is a serious thing that each one of us must talk about? And when you hit it like that, your neighbor will ask, what's happening? And you say, it's an issue on NCDs. Would like to thank him for sharing this story. You can't do it alone. We need to collaboratively do it. Could you all please, ladies and gentlemen, hit your chest? I want to hear some sound, please.
And Carol, remember
Thank you.
the other statement that if you say he is responsible, you're pointing with one finger, but the rest are all pointing at you. If you say so and so is responsible, all the other fingers are just pointing at you. So that's the level of how every one of us is supposed to be responsible for this.
But the good news is, everyone that is here today, we celebrate you. Because you are an advocate of NCDs in the world, and that means me and you ought to celebrate them.
Exactly.
We love you so much, and you're welcome to Rwanda. Our home is a very relaxed place. Please enjoy. We would like to welcome you for a photo session.
And for every moment, we never leave it without a memory. So that's why we have a photo session before we go to another program. And as we start this photo session, we are going to have a set of photos. The plan is that whoever comes here stays here and others keep joining. So I will start with this table led by the Honorable Minister of State. So you're going to have the first photo. So I think cameramen, you are all ready. So the Honorable Minister, Professor Dr. Muchumbitsi, the Mayor, Dr. Francois, let me come here. That's the first photo. After that, you're welcome here. Cameraman, please feel free to tell me if my protocol is not really good. I'm not close to becoming a fashion or stylist or something like that, but I think this is fine. Yes, thanks for representing. Yes, that's the first photo. After that photo, this group is going to be joined by a representative from the following: NCD Alliance Global, a representative from NCD Alliance Global. You can be having your way forward. A representative from African NCD Network. Then you can be making your way forward. A representative from the East African NCD Network. Then a representative from NCD then NCD Alliance, Zanzibar, Tanzania, Kenya, Uganda, Burundi, Rwanda. I'm trying to call so that my group gets bigger and bigger. So let's have this photo. Carol, you also have to join this. Carol, I'm relieving you of your responsibilities as the co-MC to the photo session. I'm discharging you of your responsibilities for now. Let's have this nice photo, and I'll tell you another group I want to invite to join here. Okay. Okay. I'm going. So another group, I'm going to, I know the other people I want to add are, a number of them are here, but if there is anyone that is part of the conference organization that is not here and is in the room, you can come forward. I see Alphonse, I need you forward. Who else? Others I think are out. Dr. Florence, I don't know whether she's already here. Then Danish NCD Alliance, sorry. You can join. You can join us as well. Yes. All organizers that are not yet here, please don't miss this photo session. These are things that happen once in a lifetime. You might have many conferences, but it might be once in a lifetime that you're in a conference and you meet the Honorable Minister of State. I'm just waiting for that moment when I will also be included in the photo. I don't know which group I should come in. So I also want to invite sponsors that are here. I see Fabrice Shema from Africa Medical Suppliers. If there is anyone from SD Biosensors, if there's anyone from Pyramid Pharma, there is anyone from the Partners in Health, don't wait until I mention your name. I'll keep on going, but if you know you are among the sponsors, just come forward. It's okay. But I'll keep on mentioning. If there is anyone from the RDA, Rwanda Diabetes Association, if there's anyone from the CBM, Team Heart Rwanda, there's anyone from PATH, there's anyone from Health Builders, cameraman, please keep on going. I'm trying to mention until I reach my name, but I can't find it very soon. If there is anyone from RBC, I think most of them are already here. So I'm told from here, you could be here, but you are not, your face is not seen in the photo. So you can go up. Please, all of you are still seated. Just bear with me. I'm also still here. I can't reach my name, but I'm still calling. Medtronic Labs. So don't wait until I call you. If you know you are a sponsor, just be here. Okay. I'm going to give a chance for all those who feel I might not reach your name, but you just really want to be in this photo. Now I'm giving it a chance. I'm making it open so that I can also be involved. If there is anyone, I have limited spots. If you want to be in this photo, please come forward. Thank you. Thank you. There are people who never miss a chance like this one. I have limited spots. Please come. It's interesting. These are photos. Yeah, just to let you know, as you're coming, after this photo, we are going to have a healthy break that is going to be strictly 15 minutes. 15 minutes. Then we shall come back here for other interesting sessions. We have experts. We have specialists in this area of NCDs. We have researchers. We have people who have done a lot of amazing things in NCD, in the fight against NCDs, that are going to be speaking to us. I think it's done here.
For those that came earlier, you can leave room for others to join. Thank you so much. You're all very beautiful.
Okay. Wait, let's wait. These people want to go very fast so that they take the whole big frame. So Okay, so we're going to have a health break for 15 minutes, and then thereafter we shall be back here. Only 15 minutes. Let's all be on time so that we proceed with other interesting sessions. Thank you very much.
Thank you so much. It's healthy for you to walk out, grab something, get some energy. We are talking about NCDs. Please do not remain seated. It's very important for you to stretch, to walk out a bit, speak to someone about what has touched you today. Have a cup of tea, and come back. You're very welcome to Rwanda, and we celebrate you. Thank you for making your time to talk about NCDs in the East African region.
They say the best things in life are free. Feeling beach sand on your toes, watching a spectacular sunset, a hike in the forest. From the clean air
iye kunyababe turajinye rumarizawe zamota tura tura Yeah, yeah. Iyo ni neza kujya iyo ni nyamubero ingendo n'amanitse y'amirano nimutemere amaso endesa natamanyije rwose
Yes, yes, yes.
iyo ni mangaza yo tarakayara nakayibaza shakaga iyo ni semwaga rwo murima iyo ndakatamanya isonga rwa rugena nyenda n'amaraza mutembero maze mwiburiye muri Zuru yahange nobu yashuru yahange umukobwa uzakamirwa n'abandi Zuru yakamirwa inyembe n'amasebe Zeruya yengo dori mwinjira mu kwirinda bana ba mama ahubwo rero nuko sate z'uburukeza barahe ntaro iyo mwizihirwa bakunda mukesha inkera nuko baraza bakuze rutabangira nuko rutangira mukarwanya mu cyaro cyaza migo rwa kibiri kiranga kigabo batari buza kumvira impuruza ahubwo rero
which was formed with the support of the Danish NCD Alliance. The East African NCD Alliance was set up in Kampala in the year 2016, and it was headed by Professor Gerald Yonga initially, and he basically took us through the formative stage, and he was assisted by the president-elect at that time, and that time within the constitution, it was not a president-elect, he was basically the vice president, and it was Professor Joseph Mukumbutsi. And the East African NCD Alliance was formed by the Burundi National NCD Alliance, NCD Alliance Kenya, Rwanda NCD Alliance, Tanzania NCD Alliance, Uganda NCD Alliance, and the Zanzibar NCD Alliance. Next slide. The area of work was basically on advocacy at multiple levels and stages, doing quite a bit of research work, trying to do a benchmark surveys from the civil society point of view, evidence for policy and action on NCDs, capacity building for the member alliances for an effective regional CSO response and general institutional development, alliances, peer mentoring, and regional NCD policy harmonization, and liaising with the regional and health organizations within the region, including East African Community, WHO Afro, and African Union. Some of the key achievements have been the advocacy work, which won actually the award in the East African Benchmark Survey of NCD in year 2014 and 2018. And you can see the two young presidents at that time, Professor Gerald Yonga in the back there, and Professor Regional Consultative Meeting at UNGA, contributing to the NCD highs on WHO Afro agenda. The East African NCD Alliance also worked on the research conference leading to the journal publication and supporting younger member alliances to form full alliances. The other achievements included the regional stakeholder engagement, including the East African NCD Charter, East African NCD Alliance being given a leading role of nascent African NCD civil society network, which currently now is an African NCD network. And the team, the secretariat looking after it, headed by Ferdinand, are here. And mobilization and participation in the United Nations high-level meeting of 2018, refocusing on empowerment of the people with NCDs and UHC. So when we talk about East African NCD Alliance and what's the purpose, we're talking of burden of NCDs in East Africa. And if you look at the burden overall globally, currently, every second, 28 lives between the ages of 30 and 70 are cut short because countries have not taken the policy, legislation, and regulatory measures to respond to the needs of people living with or at risk of cardiovascular disease, cancer, diabetes, chronic respiratory disease, mental health disorders, including preventive, curative, palliative, and specialized care. 25 out of these 28 lives lost each second occur in low middle income countries where social, economic, and physical environments afford populations much lower levels of protection from the risk and consequence of NCDs than in high income countries, including protection from the risk factors of tobacco, alcohol, diet, physical activity, and air pollution. So if you look at the East African NCD burden, and if you look at Kenya, Uganda, Tanzania, Rwanda, and Burundi, unfortunately, I could not add in the slides of South Sudan and DRC here. You can see that the burden of basically the deaths which are occurring within the East African region vary from around 27% to 44% due to the underlying NCDs. And you find that probability of the premature deaths, again, vary from around 13 to 23%, within the East African sector. And if you look at the deaths which are attributed due to the risk factors, underlying risk factors, you find that hypertension is number one, followed by the dietary risk. This is followed by diabetes, and then you got tobacco use, alcohol use, and you got the high BMI, which is contributing to the increased mortality due to the underlying risks which are there. And you can see the graph going up from year 2000 to 2015. Again, if you look at this graph, again, this is the data, which is basically from 2022, and you find that the total NCD deaths and percentage of deaths in East Africa, you see from year 1990 to year 2015, you see the total number of deaths, the graph is rising quite significantly. At the same time, the percentage of deaths due to the underlying NCD is also going proportionately high. Again, this is the data from Kenya, and from what you see is that 53% of the NCD deaths and 72% of injury deaths in Kenya are occurring before the age of 40, and that is quite a significant premature morbidity and mortality which you are seeing within this picture. And this picture is reminiscent in all of the East African countries. The other thing which we are looking at currently, next slide please, sorry, yeah. Currently we are looking at, and this is very early data from Zimbabwe, but it's practical, and we are trying to collect the data from East Africa. And what you see in HIV population, where we have now chronic disease, people on antiretroviral therapy, you can see that NCDs, the data from Zimbabwe is showing from 2015 to 2035. You see the number of non-communicable disease in people with HIV is also proportionately, exponentially increasing. And this brings about the component or the concept of the integration of care at levels of CTC and HIV clinics. So what is the underlying problem? The underlying problem, is it resources or what is it? So if you look at the budget allocation to combat NCDs in East Africa in the partner states, you see the financial allocation over the total budget. You see in Tanzania, basically it is 7.8% in 2021. In Kenya, it's around 11% in 2017, 2018. In Uganda, it's 17% in 2021. Rwanda, 13% in 2021. And Burundi, 1% in 2014. In Sudan and DRC, we could not get the data. So you find that the amount allocated within the budget for the health is significantly lower. So as an East African NCD Alliance, the first thing the Alliance did was do a benchmark survey from the perspective of the civil society, trying to see where are we as East African community, as a East African regional framework, and what is actually happening within the East African countries. So if you see, looking at the governance, if you look at the development plans and NCD mentioned within the development plans, you find it was only mentioned in Tanzania, Zanzibar, Uganda, and Rwanda. In Kenya and Burundi, it was not mentioned in the development plans when the survey was done. Where the NCD was addressed in the health policy and strategic plans, yes, it was in all the 5 countries at that time. Operational NCD strategy was present only in Kenya, Tanzania, and Zanzibar. Uganda and Rwanda and Burundi, at that time when the survey was done, operational NCD strategy was not in place. If you look at the multi-sectoral committees, I think multi-sectoral committee has been our Achilles heel. I think it has never functioned effectively. It has never been formulated. And you find that during that time, it was only Uganda and Zanzibar who had a multi-sectoral committee. And civil society engagement with the NCD alliances was extremely strong in all the 5 countries. And if you look at reduction of NCD risk factors and countries with policies and legislations and regulations, you find that tobacco legislation in 2014 was present only in Kenya. In 2017, it came into 4 other countries, which are Zanzibar, Uganda, and Rwanda. And these are policies. Whether these policies have been translated into regulations and laws is still a question. Alcohol Control Act, again in 2014, it was in Kenya. In 2017, Kenya and Rwanda. Nutrition Strategy and Action Plan, you find it in 2014, it was only Kenya and Tanzania. In 2017, it was joined by Uganda and Rwanda. And physical activity policy, basically, as a policy framework, it is not there, but there is a physical activity promotion in Rwanda and Tanzania, which is ongoing. So having looked at this component, one of the key objective of the East African NCD Alliance was to work with the regional framework and East African community and trying to see how we can actually set up some sort of a regional framework within the component and within the regulations and laws guiding the regional framework. So the East African Community Regional NCD Strategic Plan and Implementation Framework was devised for 2022 to 26, and it is because of the initiative of the East African NCD Alliance reaching out to the East African community, and we had our first meeting in July 2019 with the East African community, and we basically sensitized them, and we actually asked and started working with them. That was our first exposure to the East African community, trying to see if we can develop a regional framework for control of NCDs, and then we started coming up with a roadmap. The East African Community Secretariat gave us recommendations for the consultative meeting to bring on board NCD experts from all the member countries and work on the prevention, management, and control of East African Regional Non-Communicable Disease Framework Program. So what was this vision statement? The vision statement was the East African Community region should be free from preventable burden of NCDs, suffering, disability, and death. The mission statement is to improve the quality of life in all East African community partner states, communities by reducing the suffering, disease, and death caused by the preventable burden of NCDs with a focus on access to high quality, long-term, and equitable healthcare. And the goal is to provide essential NCD services in primary healthcare in the context of universal health coverage in all East African community partner states. So what do we want to achieve with this East African Community and NCD strategic plan? We want to achieve 5 and utilization of the WHO guidance documents for the prevention and control of non-communicable disease within the primary healthcare centers services, improve access to essential NCD services at the PHC settings, strengthen the advocacy and capacity building in all East African community partner states in order to prevent and control NCDs among the member states, enhance capacity of the PHC to human resources so as to provide NCD prevention and control services, and strengthen and incorporate NCD surveillance system into the health information management system. So these were the 5 goals of the strategic plan. So following principles will be guiding the strategic implementation. 1, universal health coverage and primary health care approach, leadership by the government, patient-centered and community-based approaches, interventions which will be evidence-based and cost-effective, bulk procurement of medicine and equipment, local manufacturing to be sort of encouraged in East African partner states for the drugs and the commodities, multi-sectoral coordination approach, and accountability of whatever is being done. And the key pillars as per the East African Community Secretariat included Pillar 1, which was adaptation and implementation of the WHO guidance documents for the prevention, control, and management of NCDs. Pillar 2 was to capacitate human resources for health strengthening to deliver NCD prevention, control, and management services at the community level. Pillar 3 was improved access to essential NCD services at all levels of care, including access to essential NCD commodities. Pillar 4 was integrating the East African Community NCD surveillance system into the health management information systems within each partner states. Pillar 5 was strengthening NCDs prevention, advocacy, communication, and social mobilization at all levels among East African partner states. And finally, strengthening the regional coordination and oversight support. Our key assumptions are that East African Community Partner State policies and regulations will continue to support the NCD burden elimination, putting advocacy at the forefront of these initiatives. East African partner states agree to strengthen the human and financial resources for the primary healthcare centers. There should be a multi-sectoral approach where all East African Community Partner States should have health in all policies and whole government approach. And there should be a maximum accountability of all the East African Community Partner States who should have a strong, accountable, and effective leadership, human resources, and financial resources to combat NCDs. And the theory of change, this is a busy slide, but basically with the inputs on the left side with financial and human resources, health infrastructure, and enabling environment. Then we'll have the key influencers, which will be East African Community Partner States, alliances, heads of state, East African Community Partner State health experts. We'll have the facilities and services and health systems together with the health universities, public health universities, colleges, centers of excellence, which are under the East African Community, at the same time, regional and global health networks. And we'll have the parliamentary forums in each of the member states, together with health information system and East African NCD Alliance and the civil society. This will be the key influencer, bringing about an intermediate outcome, which will have a strong multi-sectoral approach, strengthening the surveillance system, accessibility to essential care and essential supplies and logistics, developing the capacity of the human resources to manage this NCD, and WHO health guidance adopted and well utilized by the partner states. The primary outcome we expect is that the NCD burden and other risk factors, there will be a reduction and there will be an improved quality of care with additional resources being put into the NCD care within the region, at the same time reducing the death rate due to the NCDs and the premature mortality which is occurring due to these days. The overall impact of this intervention would be that we would have basically East African community with free from preventable burden through the NCD by the implementation of the 6 pillars which I have mentioned. And that is our overall goal. And as we talk about resource utilization, this is what you see is that the rationale. Why is there a rationale for the investment case? You see that the visible part of the burden is the government and the private health expenditure and out-of-pocket expenditure. But basically what the policymakers are missing is the invisible part of the burden, which is a premature mortality cost, absenteeism, and actually reduced workplace productivity. So with that one, I end here, and we expect to work with the East African community to put this strategic plan into action as soon as it is taken to the heads of state. Thank you very much.
Thank you. Let's celebrate him one more time. I love to see you smile. We are talking about something critical. Ladies and gentlemen, we want to welcome those people that are joining us online. You're very welcome from different parts of the world and different parts of the cities. We are happy to have you. At this moment, each one of you made this a success. Would like to celebrate all the sponsors in a very critical way. Please celebrate the people that have made this happen. Thank you so much for valuing this critical issue that we are discussing. Wow. And thank you, Professor Kaushik Rame. I cannot say what you have said until I arrive at that level. We are going to continue this afternoon, this morning, and this day. You might be wondering, but we are talking about NCDs. What is the situation of the NCD response in the East African countries? Personally, I have no idea. And I really want to know, because if you're talking about this, what is our current situation? There's going to be a panel discussion. People who know about this are going to come and speak to us about our current situation of NCDs in the East African countries. And on that note, I would like to invite someone, a very young man like me, energetic like myself. I'd like to invite Dr. George Musengi to come. When you see him walk, you will understand. He will be the one leading the panel. Please, that's good, that's good. You can lift it better. He is going to be our moderator. Could you please take your seat and then take over?
Good morning, everyone. It's a challenge when someone tells the public that you know a lot about something. I am a moderator. So people are coming who know about this. So my name's George Leonard Msengi. It is quite an honor to stand before you all. So I thank the organizing. We work together on a project with the African NCD network. She is a palliative care physician and a public health expert, but she is the current chair of the NCD Alliance of Kenya, the secretariat. Please come up front of the East African NCD Alliance. She's the board member of the African Palliative Care Association and the president of the Aortic East Africa. Dr. Zipporah, welcome. So together with Dr. Zipporah, I would like to call Dr. Francois. Yeah, Francois. Please help me pronounce it right so the rest do not call you like what I did.
Francois.
Francois. Those from Tanzania, it is Francois. Yeah. So Dr. Francois, he's our representative here. He's a manager of the NCDs department of the Rwanda Biomedical Center. He has quite an extensive experience with NCDs. So prior to managing the department, he has independently governed and coordinated the implementation arm of the Rwanda Ministry of Health. He previously served as the director of the Cancer Disease Unit from 2015 to 2019. He did his master's in epidemiology from here, Rwanda, after his medical degree. So Dr. Francois has so our director of the department has quite an extensive experience with also HIV programs, and we're quite honored to have him on board. So please, our hands together for our director. So next, we're going to call Dr. Elias. Dr. Elias, are you here? Dr. Elias Sutahigwa? Yes, these are the names I can pronounce. Dr. Elias has a Master's of Health Science and Management, but also he did his Bachelor's in Medicine and Surgery. He is a currently Member of Parliament from Uganda, and he has previous experience in working with from the community level, whereby he has been a medical coordinator, a medical superintendent, rising to the district health officer, and finally to the national technical advisor, and now as our MP representative right here. So it's quite an honor to have an MP here, and let's put our hands together for Dr. Elias. Last but not the least, can we have Dr. Patrice Barasukana. Dr. Patrice Barasukana, are you in the building? Yes, perfect. Dr. Patrice is a senior lecturer, as you all can see. He's a senior lecturer at the University of Burundi, Faculty of Medicine, a professor in neurology. He's the president of the Burundi NCD Alliance, president of the Burundi League Against Epilepsy. He's working on NCDs for more than 5 years, and he's quite renowned in terms of publications and papers. So this will be our panel for this morning, and if you allow me, I will take my seat as we move forward with the panel. So on to my side, I am a medical doctor by experience, and I'm here representing the African NCDs network. We have a team of secretariat. I always like to acknowledge the young champs at the back, please. So the African NCD network as a secretariat, but also leading a program on Our Voices, Our Views. And I'm also here because I'm an advocate of NCDs. And I work very closely with the Tanzania NCD Alliance, but also part of the WHO Civil Society Working Group, co-leading on the advocacy and communication. And I sit as a governing council member of NCD Alliance, NCD Child, sorry. So to move forward with our discussion, I will share some questions, and if we'll have time at the end, probably you can jot down your questions, and I will share with you a platform to ask the panelists the questions. So our first question will be regarding, can I pose the question first of all to our director? Yes. So the first question is regarding an obvious need for action. So there is quite an obvious need for action regarding the East African community countries regarding to curb the need for prevention against NCDs. And a lot has been done. And just to move into what has been done, I would like for our director of the Rwanda Biomedical Center to share with us some key experiences regarding what is the progress and what are the limitations, but also some of the key steps that are being done by Rwanda in terms of actions. So can I share with you the other mic, please?
10 years ago, when you went to the Ministry of Health, the Department of NCDs had 2 people working in the ministry, sharing a desk. That means there was hardly any work going on in the ministry. But following some meetings that we held 2011, actually, the ministry decided to invest in our NCD department, and now we have a whole department of NCDs with quite a number of staff working there. It has also subdivisions. For example, we have some in charge of injury and somebody in charge of mental health. We have somebody in charge of a national cancer control program. So we have come a long way in terms of capacity building for our staff at the Ministry of Health to be able to address the issue of NCDs. We had our national strategic plan, our first one, some 6 years ago, which was actually the first one that we ever had in Kenya, was really a beginning point for us. And last 2 years, 2020, 2021, we did an evaluation of the strategy to find out how far had we gone. We were able to actually see that we had done about 60 to 70.
There are biscuits, sweets, and so many things. Even when you check on our tables, there are sweets. Even here, you have provided the sweets for me. So, but I mean, how much do we know about these foods?
Yeah.
How much do we know about these foods?
Yeah.
How much? You know, we are here talking about NCDs,
Yeah.
but we are still promoting.
So I think meaningful involvement is something that we need to think about, something that we need to put across all our pillars, every pillar that we are addressing in our strategies. And I hope that we have a good representative for living the NCDs in this room, and not just advocates
we should not, of course, forget, diagnosis and the management, but we have seen it's not really, it's not easy, but if you can really probably put more focus on those, the prevention and so on. But again, research, we should really be able now to see if our interventions are working and now be able to change. Or even to adapt. So these are things that I'm seeing. So the government really is doing a lot, investing in those specialized care. We are building cancer centers, we are building cardiac centers. So there are many things that are being done. But of course, these are things that come probably at the last minute. So more focus on prevention, more focus at the primary health care level. That's how I'm seeing really, that's when we can make a real impact.
Thank you very much. So passing the mic to Dr. Elisa.
Integration. Most of the organizations in Uganda support health. Let us look at the HIV, for example. But for example, they will support a community program for screening. And but when you say, let us go and do screening of HIV, they say, no, that is not our program. But we have been able to move a step ahead. Now we have agreed, for example, with PEPFAR, with their COP 2023, they will have accepted to integrate NCD issues into their program. But the most important in this is involvement of members of parliament. And also when we revived the forum, it became easy for us to get closer to them. And also the alliances. We have the alliances which are also operating in our country, which also make us close to these civil society organizations And I think we are moving on well. Thank you.
Thank you very much. So I think they have heard. So you have heard it from Dr. Elisa. So Professor Patrice, to finish up with you, from the academic side of you, if you'd words that are easily notable, Tanzania has made progress in NCD prevention, and the calls from my sister right there happy. And she called me, she told me tomorrow morning, 6 a.m. in the morning, wearing my jogging shoes, of which I don't jog very often, but I go to the gym. And so they tell me, because you want to do an awareness, it's going to be in the end. That was a very tricky part. So you have to jog with us. 10 kilometers, I was exhausted. I had to take a motorbike back and wait for them. But this is walking the talk. But just this is an example of telling you that there is much going on from the civil society aspect, much going on from the government aspect. But most importantly is we need to progress and we do not need to stop. So if you do not remember anything today apart from mambo poa, please remember you need to progress as an individual and as a country.
Interesting panel that we just had. And another big round of applause to an interesting number 2011. He's currently the Director of Research and Innovation at the College of Medicine and Health Sciences and strives to make the college.
Imagine that our brain is connected and functions. You can describe like valleys, multidimensional valleys, right? If you have a valley in which you have a healthy mental state, we are inside at the bottom of the valley. So you can look at it as a little ball that is sitting at the valley, at the bottom of the valley of your mental health state. Now, if your stress becomes higher, stresses in your environment, the little ball is going up the hill and up the side of the valley. But then if you let the ball go, it will roll back to the point below in the valley, right? And that is what we call a stable mental health state. Now, the problem happens, or what is a mental health disorder, is if the stresses go so high that the ball rolls up the hill, but then goes over the ridge and is on top of another valley. And if you drop the ball at that moment, it will end up in a different valley, which is also a stable state. Only that stable state has characteristics that are not good for the person, right? And so that image, and that is not an allegory, that is a real description of what is happening in the brain, right? And so you see that now we don't have a quantitative difference in levels of stress. No, we have arrived in a different qualitative state of being, and now we are stable in that new state, right? And then there is ways you can solve it, so that theory you can explore it further. But so that is the concept of a mental disorder. Let's go to the next slide. So these are some key simple facts that the WHO says, like these are, if there is 5 things you need to know about mental health, then it is that 1 in every 8 people in the world live with a mental disorder. So that's a very high number. Mental disorders involve significant disturbances in our cognitions, in our thinking, in our emotion regulation, and also in our behaviors. There is a multitude of mental disorders, and I'll go into that a bit later. There is effective prevention and treatment options for many mental disorders, right? And sometimes there is the belief that once a person has a mental health disorder, this will be for the rest of their life. And for most mental disorders, this is not the case. They are treatable, they are preventable, and that is the way to think about mental health. And very many people do not have access to effective care. Can we go to the next slide? So I think really starting in 2010, there has been an enormous movement to make people, and of course it happens before, but from 2010, there's been a major movement towards stressing the importance of mental health and how to integrate it as part of the healthcare solutions. So that part of that is the global health movement, who says, like many of the problems, it's part of the global health movement, but looking at how, so an enormous amount of policy documents and vision documents and shared knowledge has been created to bring mental health to attention and to making all countries aware of the importance of treating mental health. A movement that somehow developed in parallel is the mental health and psychosocial support movement. And that is a movement that was created mainly to deal with people who are living in conflict settings. So that was for refugees so that's an enormous treatment gap. There is obviously, I'm sorry, I think you're one slide too far. If we can one slide back. Yeah, that's the one. There is obviously an enormous amount of stigmatization on mental health. And interestingly, a recent study in Rwanda showed that nurses are more stigmatizing than the general population towards mental health patients, right? And it's a good moment to reflect on yourself. It's not because you're a professional, a health professional, that suddenly you are not susceptible anymore towards stigmatization, right? Healthcare professionals are, in this study, and there's more studies going in the same direction, that show that healthcare professionals are heavily stigmatizing mental health patients. In many ways, mental health treatment, if you think about it as a disease, it's not different from physical health, right? You need to do promotion, you need to do prevention, you can do treatment, and you can do recovery. And that is the general picture to think about mental health. You think about it as other diseases that you meet. I'll just give you some few numbers that it's an important public health concern with wide-ranging impacts. So there is the, and I'll go quickly through it. So the mental, neurological, and substance use disorder, they account for the numbers pre-COVID from 2019. We're living with a mental disorder. 1 of 4, so 25%, 1 in 4 of us will experience a mental health problem at a certain point in your life. And people who have a long-lasting, a lifelong mental health difficulties, half of them, it starts like around middle adolescence, so around 14 years old and onward. That's where there is an onset, and so an important area to prevent. So here there is some more numbers just to show you the scale. And so here there is some more numbers just to show you the scale. And I'm a bit aware time limitation I got, so let me not go deep into these numbers. But you see adding up that there is substantial, it's a substantial crisis, it's a substantial health issue. Cases, it is rising. Like COVID, for example, on a global level, it raised anxiety by 24%, depression by 26%. So it is a disease that is there, and there is some reasons why it is raising. As I said, there is many documents that have been written up, global documents, to deal with mental health. And one of those important documents is the Comprehensive Mental Health Action Plan from WHO that was brought together by experts globally. So it has the objectives to strengthen leadership and governance, to provide integrated services at a community level. So in general, the movement is to go away from the big hospitals and bringing solutions to the community level, to implement strategies for promotion and prevention. And that is so important. There is a lot that is possible in promotion and prevention rather than waiting when the person has the disease. I know that is true for many NCDs as well. But for mental health, it is particularly true. And we need to strengthen information systems and evidence around mental health, which is particularly important because mental health is kind of an outsider among the other NCDs, right? The other NCDs, there is a cancer, you can observe the cancer. Mental health is a special something. We talk about dysfunction in emotions and cognitions, but you cannot touch, you cannot feel, you cannot see those emotions and cognitions. You can only see behavior, right? And because of that, it's sometimes difficult for people to understand how you can evidence mental health. right? So there is many cross-cutting principles. So we need to have universal health coverage. It's very linked to human rights. People living with a mental health disorder are specifically vulnerable and are often victim from sexual abuse or other abusers. And because of that, you need to think through a lens of human rights working with this patient population. We need evidence-based practices, which also is an interesting component, and I'll conclude my talk talking about that. You need a life course approach. As I said before, the onset for long-term mental health starts at 14 years for half of the people. So the earlier you intervene, the earlier you guide people through this process, the better the treatment outcomes will be. It is multisectoral. We need to work among, for example, and I'll talk more about the link with other NCDs. And you need to empower the persons themselves. It is not us who need to tell to people living with mental health, and now you have to do this, and now you have to do this. We empower them to speak out and be part of the solution. And that's how you reduce stigma, and that's how you create better solutions. I'm quite aware of my time, so let me try to go quick. Mental health has many causes and consequences, right? So mental health, like all disease, but in particular for mental health, is influenced by a wide range of different determinants, including social determinants, cultural, economic, political, environmental, and I'll talk also about the biological factors. So one of the things you see happening in mental health is the world around us, and in East Africa, the world is changing quickly. And there is economic development that goes very quickly, meaning there is a lot of stress that is put on our youth, or maybe some of our older people who struggle to understand their place in society. So all these changes can add up to stresses, and those stresses can result in mental health, right? There is new developments happening like social stress. And I want to particularly point out some risks, for example, that are linked to social media use. If you look at the same body, so if you look at for example, diabetes and causes of diabetes, you see that there is now an overwhelming access to salt, to sugar, and to fat. And the reason for that is that evolutionary, there was, when we were living like 10,000 years ago, there was very little access to sugar, very little access to salt and fat. So every time you got a hold of it, you wanted to eat as much as possible, right? It's the reason that we are so much attracted to those products. Now, in this time of affluence, 2 minutes, I'll get there. In this time of affluence, we have this enormous, this same attraction and this same taste for diabetes, for these products, but now it has become maladaptive. We are overly exposed to it and we consume too much of it, creating ill health, right? With social media, in some ways it is the same. At the age of adolescence, if we talk about young girls, we are very, very much interested in capturing social signals. What is my place in the society? As an adolescent, you are creating your social identity. So who should I be like? Who are my examples? And an adolescent, for that reason, is looking out very much for signals, for those social signals that inform the youth of this is how your life is going to be, this is your place in society. Now, just like the affluence of sugar and salt, now with social media, there is an overwhelming amount of that type of information. So youth, and especially young girls, are very attracted to those kind of images because they naturally, by their psychological development, their brain is telling them, we want that information to develop ourselves. Only there is an overload of it, and it does impact on our youth, right? So there is more causes, there is biosuffering, and they created like groups of women who decided to cry together to heal themselves, right? There is no WHO manual or no guidelines that tells you this is a good solution. But this is a solution that came out of suffering and that came out of culture, right? So there is a lot of that knowledge that is present in our region, that is mental health solutions, but that at the moment are not evidence-based. So there is a big research tradition that we need to start thinking of how can we capture that local knowledge, how can we make scientific concepts of that knowledge that is now implicit, make it explicit, and then develop the research methodology to evidence it, right? If we start doing that, then we can also inform our policymakers and tell them, this is a local solution, but this is the evidence, and now you should roll it out countrywide. And I think that's an important future for our region and responsibility. The region helping to find better solutions locally, but informing the whole world, because there is knowledge in Rwanda. Mental health, it's about our well-being, about our state, and you've got psychology, and psychology is the study of what to adhere better to the medication, to be cooperative, or even find solutions herself or himself to help the curative process. So we need to think not only in terms of mental health when we treat patients, we need to think in terms of psychology, like how does a human being function, and how does that information help us to provide better packages of care. So these are some references on the next slide. And then we can say Murakoze Chan.
Urakoze cyane nawe Professor Jansen. A big round of applause. I actually now wish I had enough time. I would have given him like 61 minutes because I have learned that there's no health without mental health. So, but in that very spirit, we are going to have other experts on the panel that are going to take us through this comprehensively on mental health. They are going to have between 15 to 20 minutes. These are experts, and I'm not even able to handle them. That's why I'm going to call on a very capable moderator by the names of Augustin Mulindabigwi to come and take us through this interesting panel. You know, the faster and the shorter, the better. So you are welcome.
Thank you, MC. Hi. Okay. It's good to speak after that deep and great introduction given by Professor Stefan. It was just a presentation, more than a presentation, actually, because he speaks a lot about mental health and how it links to NCDs and disabilities in general. So without further ado, I want to call upon our panelists today, as we are going to have a panel discussion around mental health in the physical rehabilitation time, but we do our best to speed up this presentation, this discussion, to have that time. So next is Eugenie Mukantengerwa, the country director of CBM Rwanda. He has a master's degree. Please come. Yes, Mukan Hagwera, sorry. A master's degree in education with the specialization in special needs education. And Vincent is at least joined a degree in public health with background in clinical psychology. He's the director of drug abuse prevention and management unit within mental health, Rwanda Biomedical Center, Ministry of Health. And he's part of the team implementing mental health interventions and strategies in this country. We are happy to have all of you here, and people want to hear from you. As the MC said, this is a team of experts. So allow me just to come closer to you so that we can discuss being at the same level. Yes, as it was told and mentioned, we are discussing the mental health and disability among other NCDs. Starting from my left, Dinamo. You have been working with RBC for many years, and you have that extensive experience in management of mental health. Can you tell us how is mental health in Rwanda? Can you give just a snapshot, a picture? How is it?
Thank you very much. Good morning, everyone. I was expecting to have a presentation, but since Auguste is asking me to give a situation, it's not a big challenge. But I can tell you that we are fit in mental health, and everyone here, I think, is fit in mental health. But when we look at in our country, we can say that mental health in Rwanda is having a history which may be having some challenges related to our background of our country. But globally, it's known that mental health still have some challenges related to stigma, like Professor Stefan was talking about. But we can just look at the three main gaps globally that are affecting mental health. Maybe after I come back to Rwanda, I can tell you that since the time mental health has been neglected and less financed, less in treatment, then after I can tell you that the workforce globally is still one of the challenges that are affecting mental health. So this is due to what? I can tell you that this humans depression is also one of the challenges that we're having today. Of course, resulting to genocide and other social problems. We can also say that the mental health problems that we're having today also are coming from domestic violences, child violences, and other psychosocial problems that we have today, like alcohol and substance abuse that can be one of the consequences, or maybe can also cause mental disorders at large. Have had one psychiatrist and the only three. But when you go back to this issue as one of the priorities, we have up to date we have or around 2,000 clinical psychologists trained. We have around 14 psychiatrists, medical doctors who are trained in mental health, and we have around 500 mental health nurses who are specialized in mental health. So the integration of mental health care in the primary care in Rwanda is supporting us to alleviate all issues related to mental health problems. Those are especially to respond to those who are affected by 1994 genocide and its consequences.
And keeping need a rehabilitation at the different part of our life and different health conditions. Like as we get older and we need assistive devices, we need a rehabilitation to function. And that's why we say that this is rehabilitation is a issue which has to be addressed very systematically within Ministry of Health. Of course, it has to be a major rehabilitation is done in community, but also has to be done at the tertiary and the secondary level. So with this rehabilitation stage, have a facility where they can access to assistive devices. Simple assistive devices can be provided in a health post or a medicalized health post, what Rwanda has, where the nurses can be trained in providing a simple devices like crutches and walker. Easily done. WHO has come up with a package called training for professionals, TAP.
Also tackling other issues faced by persons with disabilities and which hinder their development and even their participation in the community life. And those challenges are mainly discrimination, those related to livelihood, those related to exclusion, issues related to education, for example, to employment, and so on. So all of these other issues, CBM is trying to address them through a range of programs, for example, programs for inclusive education, programs for livelihood, programs for physical rehabilitation, and even programs for advocacy for the rights of persons with disabilities to try to address the issue of discrimination. Thank you.
Thank you so much for sharing with us the uniqueness of the approach used by CBM. We may come and learn from you. When you were talking, you spoke about holistic, inclusiveness, humanity. And Mr. Vincent, you have something to say about it?
Yes, sure. Thank you. Let me take you through what we are currently dealing with in terms of promoting inclusion. And humanity and inclusion is formerly known as Handicap International. So we are in Rwanda supporting the government initiative and policies meant to promote the rights of persons with disabilities, but also the rights of vulnerable people in general. So as Handicap International, our philosophy is built on allowing persons with disabilities to enjoy their rights and achieve their potential. In doing so, HI is currently promoting different aspects of life. In Rwanda, we are promoting health through maternal and child health, promoting rehabilitation, occupational therapy, mental health and psychosocial support, fight against epilepsy, but also nurturing care. All those domains are meant to allow Rwandans to fulfill their potential to achieve it fully and optimally. So let me focus on mental health. In promoting mental health, we are promoting a community-based health approach. This approach is not new, but is not common. We are believing that doctors, psychiatrists, psychologists can treat patients, but if the community brings more substantive inputs, this yields more successful results in that patients can recover quickly. Patients can socially construct their esteem and socially and economically resume to their work and improve their autonomy. That's what we believe. To do so, we have a twin-track approach. Track one is empowering the individual. Track two is supporting the system to become an enabler. And through supporting the government of Rwanda, the Ministry of Health and the Rwanda Biomedical Center, we've been able to support policies to become fully inclusive for different domains that I have mentioned earlier. Another layer is supporting system of service to become inclusive. And through this aspect, we've been working with Rwanda University, College of Medicine Sciences to promote quality in terms of skills. And we are promoting skilled labor force in rehabilitation, in occupational therapy, and also supporting mental health initiatives. This community approach actually is targeting to strengthen the community layer. And that's where I want to focus on. After the 94 genocide, Rwanda was critically affected in all areas of life. And the people had psychosocial, psychological effects, depression, anxiety, phobia, panic, etc. So to overcome those challenges, we had to go to the local ground to work with community members to entice their motivation to become part and parcel of rebuilding a conducive one in society. And this approach of mental health at community level has worked.
Okay. Yeah. Thank you so much, Mr. Vincent. The time is running. And I think people would like to hear more from you as experts here on the stage. But I wanted to ask each of you to just provide a takeaway message using at least 30 seconds. Can you, Dinamo? Can you start?
Thank you, Auguste. I can just say that mental health, however, mental health has many problems, like I said before, but there is still a long way to go with commitment of everyone, especially in fighting against stigma and discrimination, and of course, calling from those governments, officials, those who are politicians, and everyone here or aware to make sure that no health without mental health. And we have seen that decentralization and integration of mental health care was one of our responses. However, we still have some gaps, but many things have been done. We are planning to do more, and we're expecting you to support us in that way. Thank you.
Thank you so much. Message taken. Yes.
Yeah, thank you. For your take home, I advise you to understand disability. Disability actually is a limitation to performing life habits. So let's overcome the double burden. Disability can cause mental health, and likewise, mental health can cause disability. So to take home, I need you to at least remove barriers that make disability to occur. Secondly, the community plays a role in unlocking challenges related to mental health. It's better to become enablers, like supporting people who are suffering from mental health to recover. Last but not least is on service level. To make sure that our services become accessible to persons with disabilities, I would urge you to adapt your tasks, render your services more accessible in terms of reach, saturation, and utilization, and more communication. Thank you.
Thank you. Message noted.
Thank you. I would like to invite everyone to work in partnership so that we can provide comprehensive services to persons with disabilities. Yeah, which means that we need to ensure that our services, our different services, health services, community services, and the other services, all our services are disability inclusive. To get there, we need to work in partnerships. We need to bring in people with disabilities and their organization. We say that that is the emotion of people with disabilities. Nothing for us without us. Let us work together. And also to say that disability is not inability. People with disability only need enabling environment. Thank you very much.
Oh, thank you so much. It was very interesting. Yes.
Thank you.
For me, I will really urge all the government who was representative present here. It's very important to strengthen rehabilitation in the health system. And we have a very good WHO package which is available. And it allow us to make a systematic assessment of rehabilitation situation in the country. And once we have the situation available, we set priority and we develop a strategy that how we go systematically to provide the rehabilitation services at primary level, secondary level, and tertiary level. This is a rights for person with disability. Health is right, rehabilitation is right, and it must be integrated into health system and community level as well, so that every person who needs rehabilitation services, they access it and they access their basic right, because rehabilitation is the first step before person go for education or a job or a recreational activity. And definitely we need to promote the person that we see the ability inside the person, not focusing on disability. Thank you.
Thank you so much. Ladies and gentlemen here, this is the end of our panel discussion. These experts needs your gesture to show that you are happy. You deserve more. You deserve more until you reach where you have the seats. Thank you so much.
Thank you very much. Another big round of applause to the moderator now this time, because he requested for a round of applause to the speakers. But honestly, you can see that it's very important to talk about these issues. I know we are in a rush, we are time bound, but it's very important that we talk about these issues. We are going to keep engaging them as we go for lunch, right?
Ladies and gentlemen, everything is safe here. So please go enjoy your lunch. 45 minutes English time. You can leave your bags and you'll find them here. Thank you. Your laptops, your phones are safe. So please don't worry. The dollars, the mafarangas are all safe here. Enjoy your lunch. Bon appetit.
Musiciens qui sont parmi les plus importants du monde contemporain dans le domaine du jazz, du jazz, du jazz, du jazz. Thème, on fait une composition en plusieurs mouvements. Il a enregistré récemment un disque aux États-Unis. Le titre en est Love Supreme. Love Supreme. Love Supreme. Le saxophoniste John Coltrane.
Yes. Yes.
Right. Right.
Allô? Genda mano uvuge, genda uvuge. Ndakuvugisha, ndakuvugisha. Olivier? Charles.
Yes, 20. Yes, 20. Yes, yes.
Yes, yes.
Olivier.
Are you catching me? Yo, ndabumva jewe muri kunyumva mwebwe?
Yes, 20. Olivier.
Njye ndabumva.
Yes, 20. Yes, 20. Yes.
Check, check,
Yes.
check.
Yes.
Check.
Olivier? Olivier? nawe nturi kumwumva uri kumwumva wowe ntabwo uri kumwumva Olivier? Olivier?
Alexis?
Uh,
Alexis?
Olivier?
Yes, Alexis. Alexis?
nanjye ijwi ryiwe ngiri hano
Alexis, Alexis? Alexis? Yes,
Olivier? Olivier?
ndabumva jewe muranyumva mwebwe muriko muranumva? Muriko muranumva?
Olivier? vuga cyane man
You can see these are the people who have made this event a possibility. They have made it happen. They have made it a reality. So we have all of them here. We recognize you. And I know most of you have representatives here. And there are those who are not here and they're outside there in the booth. Please, the moment every time we move out, whether it's during any break, make it a point and pass by. See what they're doing. See those ones who are giving us services, those who are doing testing, those who are presenting their products, different products that are related to the fight against NCDs. Okay? Another thing that I want to remind you about is our online presence, please. With our hashtag NCD Conference 2022, please make sure you are tweeting, you are retweeting, you are reading what people are saying about this conference. Okay?
Thank you very much. When you see a man standing, gender balance, when we talk about NCDs. Ladies and gentlemen, this particular afternoon, we're going to have a very critical discussion.
I'm already excited about the discussion that are about to happen here.
On availability and accessibility of NCDs in the East African region.
And actually, without any further ado, allow us to welcome our very able moderator for this session, who is
Let's celebrate the strong lady walking exactly like me. That's how I walk when I want to show that I'm strong. Celebrate her. That's exactly how I do it. You're doing it right.
Natalie Bera is here to take us through this panel. It's going to be very interesting.
As you see her walk, please celebrate her. That's I'm going to walk right after the conference because NCDs is a very critical issue. We'd like to hand over to you and we trust you to be just as we are doing to make sure that we finish everything today. I thank you on behalf of the team. Thank you.
Thank you so much for the nice presentation. I'm super honored to be here and to moderate this session. And in interest of time, I think we should just get started. This is the panel discussion about availability and accessibility of NCD care in the East African region. So first of all, I'd like to welcome Maria Kidner from Team Heart. She's an advanced practice nurse specialized in cardiac education and care in the East African region. Welcome, Dr. Maria Kidner. Next, I'd like to welcome Dr. Christian Nitisima, founder and executive director of the African Center for Research and End-of-Life Care. He's a pioneer and a specialist in palliative care in Rwanda and in the East African region. Welcome. Next, I'd like to welcome Dr. Mark Hajinimana, the acting director of the Cancer Care Unit at the Rwanda Biomedical Center. He's public health specialist with more than 7 years of experience in providing cancer prevention and control in the region. Welcome. Next, I'd like to welcome Mr. Fabrice Schema. He's the owner and managing director of African Medical Suppliers, and he's representing the private sector here today. Welcome. Next, I'd like to welcome Dr. Josephat Samoy from PATH. He's a supply chain specialist and an expert in access to NCD medications and commodities in the East African region. Welcome. And last but not least, I'd like to welcome Professor Kaushik for you to share a little bit about the Trainer program. And maybe if you can also share with us your perspectives on how we can bring the cardiac care closer to the people and increase the availability and accessibility of care. Thank you.
Thank you for this afternoon, and that's quite a question to answer. So the first one is Team Heart has a program. Team Heart has been around since 2009. They provide services and resources and education for rheumatic heart disease, and they provide cardiac surgeries free of charge several times throughout the year for rheumatic heart disease. Nursing was found to be a professional group that could increase their education. So we developed a program called the Specialized Cardiac Nurse Train the Trainer. The Specialized Cardiac Nurse role is based on advanced practice nursing. It is based on the American College of Cardiology 2020 competencies for nurse practitioners. And so we developed a program for comprehensive education that included the history and the physical exam with stethoscope. We've included the understanding of 12 lead EKGs, labs, echoes, chest x-ray interpretations, along with a variety of pathologies that were taught throughout the year. These 6 students are master prepared students. This is a postmaster program. We have 3 that are education from the University of Rwanda, and we have 3 that are ICU nurses from different facilities to increase the perspectives and to make a very good discussion point. I would like my 6 students to stand so you know who they are and you can talk to them.
Give them a big applause.
So this question that you asked then was about bringing the program or bringing access to care to the people. Exactly. Well, one thing that I look at the access to care is to high quality and knowledgeable providers. And the role that we are developing, that we hope to develop in the program that we would help to be sustained, the specialized cardiac nurse role is really key for that. This is an advanced practice nurse that can do all of the care, the assessment, and understanding the critical aspects and get everyone ready for evaluation and referral to cardiology. So bringing the access to care, this nurse, one of our strong points is as educator. And as educator, the SCN nurse can be educating your NCD nurses on a higher standard to be able to do assessments with a stethoscope, actually hear the sounds for heart failure, and to pick up murmurs for faster referrals. The SCN nurse then would be paired with a cardiologist And that's where you have one cardiologist and one well-trained nurse, and you get 3. So you increase the capacity and the ability to go. Did you have the third question?
It's
Is that one later?
I have a third question, but I think I will jump to the next panel.
I can hardly wait for the third question, so I'll send it down.
Maybe we'll get back to you. But thank
Okay.
you so much for your answer. So my next question is for you, Dr. Christian. So considering your extensive experience and long-standing work in pioneering the integration of palliative care services here in Rwanda and the East African region, we would like to hear what your biggest achievement has been and what your greatest learning experience from working with palliative care here in Rwanda. And then we will also maybe like to hear a little bit about how we can increase the awareness about the available palliative care services that's here in Rwanda and how we can also bring the knowledge out to the people who needs it.
Thank you. It's many questions.
Yeah.
Yeah. So thank you again, Professor Muchumbisi and the team for the invitation. And I'm happy to be here and share my small experiences. I think my achievement for the first question, I can say 2 points. One, it's a personal achievement. It's when I moved from my dream to be a surgeon to become a palliative care passionate. Because my dream was to be a surgeon until I met a very young guy, 24 years old, who was dying with liver cancer. And the sad story is mom came to me and knelt before me and asked if I can give something just to help a child to sleep and wake up no more. That time I feared to prescribe morphine because there is a myth beyond using morphine that if you prescribe morphine, the patient will die. And unfortunately, I didn't prescribe because I feared that I would go to in jail because that was the myth, of course, that time. And when the patient died the next day, I questioned myself what the reason to spend so many years in medical school if the reason is just to be a witness of lack of humanity by doing medicine. And since when I moved from my dream to be a surgeon to become a palliative care patient, so that is, I think it's a personal achievement. The second point is it's a national achievement to be part of the journey when the Ministry of Health in 2011 Rwanda became the first country in Africa to launch the national policy in palliative care implementation plan and guide plan for 4 years. And because that time morphine was using in the country was only 0.2 kilogram of morphine. And you can imagine 0.2 kilogram of morphine can treat only 27 people. And since then, through the Ministry of Health, the program, we were able to train people and also increasing the access of morphine. And we move from 0.2 kilogram to almost 20 kgs of morphine now, if I'm not wrong. Even if the estimation of the whole country, it's approximately 97 kgs of morphine a year. So I think that is the two in terms of achievements, personal and also national level. The lesson learned is palliative care is not about death and dying. I just want to clarify. People think about palliative care, it's about death. Palliative care, it's about life. It's not about death. And it's really unfortunate when I mentioned that I'm doing palliative care, people think that I'm focused for people who already condemned. But I have a good news for you all. We all die one day. Later or sooner or later. So I think the most important thing is, and it's statement I like to share, the way people die can reflect how the society live. So if we need to focus on the life of people, including prevention, control, treatment, care, and palliative care. So we need to focus on the person instead of to focus on disease, because if you treat the disease, you can mistreating the person. But if you treat the person, you cannot mistreating the disease as well. So I think that is my answers. Thank you.
Thank you so much for your inspirational talk. And now I'll pass on the word to Mark Nimana, and my question for you is, what would be your best advice for how we can improve the NCD care and bringing the cancer care closer to the people? So more specifically, how can we integrate the cancer care into the primary healthcare facility level? Also considering the high economic cost related to treating cancer people living with cancer, and also considering that many people here have like long travel distances to reach the care and the treatment that they need.
Thank you for the good question. If you can see cancer management and control in most of low and middle income countries, you can see that there is limited access of the general population to cancer prevention and services. Most of them, you will realize that sometimes cancer is not given priority. Most of countries or most of hospitals and health facilities are focusing on infectious diseases. But all of us, as we know, as the aging is increasing, as our life expectancy is increasing, look at the control of infectious disease. We are almost all of us candidates. If I can give, for instance, what we did in Rwanda, and then say what countries can consider to improve access to cancer diagnosis and treatment. In the past 10 years in Rwanda, we were having like issues on cancer prevention and control. We're having, cancer was considered as a killer for everyone. And they were limited cancer diagnosis and treatment capacities. But even if they were those services, they were underused. But we managed to scale up different services at all levels, starting with integration of services at all level, at community level with awareness, with community health workers, at health facility level with the screening services of many cancers, at district hospitals with improving capacity of diagnosis, initial diagnosis at least, including like biopsy, including like basic imaging, but also improving a proper linkage to cancer centers and many referral hospitals, and proper cancer registry and patient navigation. We managed to increase the number of cases that we were having in the past 10 years from around 600 in 27 up to around 5,000 new cases in the last year. So you can see that the number of cases has been increased 10 times. In summary, improving access to cancer care, countries should prioritize establishing a national cancer control plan. You're not able to provide all cancer services at all levels, but having a clear costed national cancer control plan, providing a priority, defining the package of services that should be delivered at all level is a key to have like a strong access to cancer services. That's the first. We need to have like a proper national cancer control plan, providing what should be provided at community level, what should be provided at primary health facility level, at secondary level, and tertiary level, and having a clear linkages of those different level of health services provision. You need to have a cancer registry to have like data informing your decisions. You need to have a policy that determine services to be given at each levels. There's a need. Cancer, it is a multidisciplinary disease. It is not like malaria or other disease. It is require multidisciplinary approach for treatment. Having a clear patient navigation system is very helpful. In Rwanda, we are having patient navigation system helping to make sure that we are not losing patients across the journey of cancer prevention, diagnosis, and treatment. And finally, I would like to say that all of us, we know that the cost of cancer is somehow high compared to other diseases. Having a community-based health insurance is a key. Some governments are providing a cancer treatment for free. I think Tanzania and other countries are providing treatment for free. If countries can manage to support a patient to have free access, it will be a key for access. But where it is not possible, having like a community-based health insurance covering most of cancer services is key. In Rwanda, we are having a very high coverage of community-based health insurance, around 90%, and most of cancer care and treatment services are covered under health insurance. In summary, it's better countries, health facilities, government have work together to have a national cancer control plan. That's first. Second, it's better to have a community-based health insurance that is covering most of cancer services. And again, it is better to prioritize and define the package to be provided at all levels, and having like a clear referral pathway and patient navigation, as well as involving a partnership of private sector, civil society organization to ensure that there is equity and to access to all cancer diagnosis and treatment services.
Thank you so much, Dr. Mark. That was very insightful. So we'll jump right to you, Fabrice Schema. So I'd like to know, where do you see the private and the public sector working better together to improve the access to NCD care? So maybe you can also touch a little bit upon the major challenges and where you see room for improvements. And also, I'd like to know, in case that the government is not able to meet the demands required to bring the necessary care to the people, how do you see the private sector step in that case?
Thank you so much. And it's a privilege for me to be here this afternoon representing the private sector. As one of the major actors on supply chain in Rwanda, I can first start to appreciate the good collaboration the private sector is having with the public. Sometimes people will really take it for granted, but when you go back and look, let's say 20 years ago, just to give you numbers, a patient with NCDs, let me take hypertension or diabetics, in order to monitor himself home, because you know it's not curable disease, his average or minimum spend was more than $200, including, let's say, small things like glucose meter and blood pressure machine. Today, the price, which was $200, you can monitor it with $20. So sometimes you can say, what's happening? There's a competition worldwide, there's a policy in place, there's accessibility, but also there's a goodwill for the government to understand that if we try to reduce the cost of access, we give more opportunity for people to monitor their disease easily. Today, I think it was 8 years ago, the insurance, all major insurance in Rwanda could not allow a diabetic patient, for example, to get strips and monitor himself back home. The only package you have to do is to go to the hospital. Maybe imagine now a person who has to control his blood level every day spends the half of the day to the hospital just to get diagnosed, meet the doctors. And today, by the collaboration with all the insurance, we are able to sell up to $9 for 50 strips. So if you come down, you try to put the cost, that person is spending now less than $0.3. to test himself. So we can't reach that level without a collaboration with the government. Yes, of course, we have a long way to go to still have all diseases, including cancers, much accessible to the population or to the sick person. So the good things, again, we are doing with the government, it's investing in research and development. We are moving from new technology areas, whereby, for example, in the next year or now even people are starting to do intensive research, where we are moving from the blood glucose monitoring system to a continuous glucose monitoring system. It's an integrated IT with a smartphone, with a device which will be putting under skin, which can give you an alert when your blood sugar is lower or down anywhere. So that technology also is helping, and we are hoping that the government sooner, they'll also embark on that. So it's a good thing to thank the governments, I think, for Rwanda and East Africa, that they have a willingness to really move forward and collaborate together. Some way of improvement. We know in the rural area they're more affected and they don't have means. If possible, to bring out the minimum package of NCDs to the healthcare, this will improve so much any early detection and even treatment on time. Yes, the private sector can play a very key role when the government is absent or with less means. The private sector, we have a policy or a social responsibility part, but the only thing is sharing information. And I hope, because we do it ourselves, that to give back to the community is the best we can. So this, the CSR, it's a very key to really anticipate or contribute where the governments may have some weakness or couldn't give it the best of its best. Thank you so much.
Thank you so much. So, yeah, the management of chronic diseases requires access to important medication and technologies. But in many low and middle income countries, these resources are insufficiently available. So I'd like to ask you, Mr. Josephat, from your experience working with the health system strengthening and innovative approaches to health services for all, can you share with us your best learning experiences and the key focus prioritizations in order to improve the accessibility and availability of NCD care in the East African region?
Thank you very much. So from PAT and partner implementation perspective, really looking at the challenges towards access to appropriate care and actually medicine access for NCD patients is quite a very critical, and it's still catching up as compared to the other communicable diseases. So as PATH, we've been able to partner with governments, especially within East Africa, Ghana, and other low and middle income countries, whereby we take an health systems approach to really see how do we impact, especially the supply chain, first by ensuring that we are able to know the patient. We all know, unlike the programs, if we ask a typical country manager how many mothers delivered in the last 1 month, they are able to tell you that with a fair level of accuracy. But if you ask who took insulin in the last 1 month, we don't know as countries. We mostly go back to the surveys that has been done in the past. So really, our major starting point is in terms of service delivery to do a lot of investment in terms of trying to know the data for the patient, and then subsequently in terms of service delivery to be able to unlock some of the barriers that our patients encounter. Case in point is really trying to strengthen that primary healthcare approach, which is clearly very closely networked to community strategies that these countries are implementing. So that said, we also need to really strengthen the EMR systems in place to make sure it's responsive to not just the other disease conditions, but also incorporate the NCD support. And more specifically in terms of addressing the supply chain for medicines, we prefer to take a human-centered approach where we work with the person living with diabetes, for example, to understand what are some of the challenges they are facing. And in this case, case in point is, for example, as my colleague has mentioned, access to insulin and access to self-care products. The patient is not able to administer insulin until they have the syringe. So we've co-created a care pack that will then enable this patient to care for themselves, be able to pick the monitor and track their blood sugars along with that. So that is another aspect in terms of innovation. And in strengthening a case for procurement for NCD medicines is really being able to forecast and supply plan for NCD products. What basically works so well is the discussion around integration, where we realize that our patients are largely comorbid. An HIV patient with hypertension is not stable until they're able to access all these products. So we also run initiatives to try and integrate patient care, where we really try to look at the whole complications the patient is able to encounter. And also in terms of supply chain, as much as we talk about integration, we really don't want to lose out the focus on NCD supplies and making sure that a patient is across the different points of care, they are able to access these services. So that is some of the integration work that we've done. And in Ghana, for example, we realize there's a lot of idle capacity for vaccine cold chain, yet we see challenges with insulin, for example. So we take a systematic approach towards partnering and leveraging on local context so that countries are able to have their own independent interventions towards NCD care. Thank you.
Thank you so much. So, Professor Kaushik Ramaya, my question for you is, from your extensive experience working with the WDF and improving the diabetes prevention and care in the sub-Saharan region, we would like you to share with us some experiences from the ground, maybe related to the programs about the type 1 diabetes patients. And maybe also if you can talk a little bit about how do you see these programs being scaled up to a larger extent, and also what you still feel is needed in this area?
Yeah, thank you very much for those questions. If you start with type 1 diabetes program, I think if many of you have read the literature, about 10 years ago, 15 years ago, there was a paper in Lancet saying that a child with type 1 diabetes in Africa would not survive more than 6 or 8 months. Maximum life would be about 12 months. I think with an access to care program, with a Life for a Child program, Changing Diabetes in Children program, we have managed to bring about insulin into the region. We have been able to start the program. And I think most of the countries, I think in the African region, there are probably more than 14 to 16 countries who are running a very effective program on children with type 1 diabetes. The insulin availability is already there. The question is whether we are reaching the last mile, because the question is the insulin goes up to the health center. From the health center, when it goes to the homes, whether the child has a food to eat before he takes insulin, or he takes insulin, he goes to the school, and there's a huge amount of stigma at school. So he does not take his second dose, which he's supposed to take in the school. So you find that even in some of the schools, the experience has been that if there's a child with type 1 diabetes, the school will not admit him into the school because they say they cannot manage him if there is no school nurse. So you find that there are a lot of challenges getting good control. So children are surviving now with type 1 diabetes, but I think probably we are actually heading for a large number of complications in these children as they grow up, because the control is poor. The average HbA1c of these children is anywhere between 10 to 12. I think there are very few countries have reached less than around 8. And you find that the retinopathy, the nephropathy, is quite basically becoming much more prevalent in these children. So question now is, how do you fine-tune this program? The second one is that for every child whom you are diagnosing with type 1 diabetes, probably in a semi-urban or a rural area, there's another 1 or 2 child who is not being diagnosed and is probably dying of being diagnosed with something else and not getting insulin. So I think the access and availability of the services up to the last mile, and how do you actually ensure that whatever products they are getting, it is being used effectively, I think is the biggest challenge in the region, I think, at present. So the program needs a fine-tuning to make sure that we provide quality care to these children. Coming to type 2 diabetes, I think the story is the same, because most of the clinics with type 2 diabetes, the drugs for the diabetes or non-communicable disease are not free of cost. Very few countries have got free access to drugs. So patients have to come, they have to do a co-funding, there's an out-of-pocket expenditure, and then the drugs are probably divided into several doses. In a sense, they're supposed to take 3 tablets a day. You take 1 so that it goes on for next 2 to 3 months. So you find that, again, the control is very poor. But most important thing is that the epidemic of type 2 diabetes, which we have in the region, is mainly related to, most likely, it is related to the lifestyle. And I think what we are missing is that piece of puzzle between the clinic service and the community, and that is the lifestyle modification. I think if you are going to really manage these people with type 2 diabetes, we need a stop in between the patient or the client going to the doctor directly or going to a lifestyle clinic, whereby he is given a huge amount of counseling on physical activity, about diet, and about the other risk factors. So I think that is what we are missing. And you find that the doctor hardly spends less than 5 minutes with a patient with diabetes. And you find most of the interface is between nurses and the patients. So you need to strengthen the nursing cadre to make sure that appropriate diabetes education and lifestyle modification is done. So I think those are the challenges which we have.
Thank you so much. So my last question will be for you, Maria. So tackling cardiovascular disease requires extensive means, sometimes which are hard to meet or find here in these local health systems that we are facing. So building on your commendable work with Team Heart through cardiac education and care, what would be your suggestions to strengthen the availability of sustainable programs to tackle CVDs in a cost-effective way, also fitting the local context? It's a difficult question to have.
Been waiting for it.
Okay.
Difficult question. Thank you. So I would like to build upon the education of nurses, because I believe that nurses are the key solution to NCD in all of the countries that are represented. So take a moment first to talk about advanced practice nursing. So I'm not sure everybody knows, but advanced practice nursing that I know of in the countries in Africa are South Africa, Botswana, Eswatini, Ghana, and Tanzania and Kenya are in active preparation for an advanced practice program. So the advanced practice nurse by ICN standards is a graduate nurse who's had extensive education in history and physical, pathophysiology, pharmacology, and differential diagnosis. So where I'm from, I am a full independent provider, so I have the same scope of practice as a physician. So I see all my cardiology patients on my own. When they need referral, I do it. But as also said, the physician often can only spend a finite amount of time. So it's the nurse that does the education. So I spend a lot of my time with my patients educating so they understand what are the medications, why do they take them. In cardiology, after your heart attack or surgery, we're going to send you home with 5 medications. And so trying to teach that so that the family understands and the patient understands is critical. So the 2 roles that I talked about today were an SCN role. The specialized cardiac nurse role would be an advanced practice on a little bit different level because Rwanda has not started the APN role yet they have capacity because the University of Rwanda teaches an excellent master's program and a PhD. Those are the NCD nurses and the NCD teams. Give them the knowledge, the skills, and the tools to make a difference.
Thank you so much. So now I think I want to engage the. Oh, okay. In lack of time, I think we should move on and thank our fantastic panelists here today, and for all your great answers to my very hard questions. So give them a big hand. Thank you.
A big round of applause to this interesting panel. Is the visit of Kigali. Basically, we'll move around Kigali, and it is trend. So it's not just like you're moving in Kigali in a bus. You're literally moving on top of Kigali. And it's going to be in the evening, and it's very sweet in the evening. At night, you see the best, you have the best view, and it's literally in the air. Yeah? So you go register. So here's the thing. You register, and you'll pay 20 USD to do that tour. 20 US dollars. But if you are more than 30 people, you are going to pay 15. So when we finish the session, you find some people there where we pick the badges, they'll register you. So if you pull a friend with you, you are already doing justice to yourself because you are increasing the number and the cost is going to be very low. Okay, that's the deal. Please don't miss the tour of Kigali especially if it's your first time in Kigali, or if you have been in Kigali and you have not been moving around. It's going to be the whole tour. It's not just like you are moving in a bus if you came through the airport then to your hotel. You are moving in the air and you are having the nice view of Kigali. Trust me, you'll be telling me tomorrow. You'll thank me later. So, very interesting. Today we have another important person amidst us, and I'm going to call him to give us his keynotes, and then it's a slight change from the program. So we have the country representative to Rwanda of WHO, and that is none other than Dr. Brian Chirombo. He's going to give us his keynote, and then we proceed. After that keynote, we're going to have another keynote, then another panel. It's interesting. We are having a number of interesting people speaking to us. Dr. Brian, you are welcome. Technicians, sorry. Technicians, be ready to put up his slides. All right, thank you.
Professor Mukumbitsi, Rwanda NCD Alliance chairperson, organizers of this very important conference, colleagues, ladies and gentlemen. It's really an honor for me to address this august gathering, this regional NCD conference on behalf of the World Health Organization. WHO values the partnership with the NCD Alliance in Rwanda and the East Africa NCD Alliance and other partners as we work together in addressing this big issue of non-communicable diseases. Next slide, please. So I will give a quick update. So I'll be talking about strategies for strengthening health systems in using integration of NCDs into universal health coverage. So I'll give a bit of a background before I talk about some of the strategies. I know in the morning, most likely you did receive some of this background, but I needed to make sure that when I talk about the strategies, we can contextualize them. So NCDs are actually now the leading cause of death globally. NCDs kill 41 million. So if we look at 2019, 41 million people died from NCDs. And this is almost 3/4 of all deaths globally. For me, this is a really sobering statistic. And it's really interesting that the way we structure our health programs to some extent doesn't even seem to take this into account, that NCDs are now the drivers of mortality and even morbidity. They are now beginning to drive morbidity, and this is globally. When we look at our own region, the region of Africa, the proportion is variable. It depends on country, because there are other countries where we do have a higher incidence and as a result, higher mortality contribution by NCDs. So this ranges from almost a quarter, 30, a quarter of the people who die being because of NCDs, so about 27%, to as much as 88%. So we even have countries where the contribution is as much as 88%. We are seeing a demographic transition. There's a change in the population dynamics. And as a result, we are seeing a more increasing association of risk factors. And I think I will just highlight some of them. And the contribution of NCDs to total mortality has been going up. So if we look at our own region, in 2000, it was only about a quarter, or 25%. But this has gone up to almost a third, to 37%. So even though globally, as a region, our contribution of NCDs to the whole mortality is still a bit lower, but it's going up very quickly. And over the same period, in our region, the deaths from cardiovascular diseases has risen by 30%, 31%. Now, so we can see that the burden of non-communicable diseases is going up, the risk factors are going up, the contribution that NCDs have to mortality and morbidity are going up. But more scaring is that the capacity of our countries and our systems to diagnose early, to manage, and to care for NCDs is really very weak in most of our countries. So it's a complete mismatch. Rising incidence, rising mortality, rising morbidity, but our capacity is not any better. And we all know what happened during COVID-19. It was those who have comorbidities who tended to have more severe disease. It was those with comorbidities who had much, much higher mortality. In addition to that, our region has a very high burden of severe NCDs. Like type 1 diabetes, we've already been hearing about the challenges with providing treatment, rheumatic heart disease, sickle cell disease, and unfortunately, these conditions, if left as they are getting worse, actually worsen the inequalities that we see. Because those who have can access services, whilst those who don't cannot access these services. And this is going to affect our progress towards Sustainable Development 3, particularly Target 4.1, on reducing premature mortality from NCDs. We see, for example, that the number of people who are living with diabetes is skyrocketing. This is real skyrocketing. It's estimated that we had 19 million in our region in 2019, and this is expected to more than double to 47 million by 2047. If we look at access to medicines, we already heard a bit about some of the challenges. Only a third of the countries in our region are reported to have essential medicines. NCDs are available, our medicines for NCDs are available in the public health sector. So this really paints a very, very worrying picture in terms of NCDs. I'll just highlight, I won't go too much into detail with this, but I wanted to just highlight some of the, based on this picture, here are some of the priorities in our region that we have for addressing NCDs. So we need to make sure that we use a multi-sectoral approach. And this means we have to address issues of leadership. We have to address partnerships. So this can't be done by Ministry of Health. It needs all partners on the table. We need to make sure we have all the tools. We focus on the best buys, those interventions that really work and make a big difference. And then making sure that we have policies, strategies, and plans. And we're already hearing about the importance of those earlier in the other discussion. Capacity building is a key area so that we can have early diagnosis, screening, and treatment, and also address risk factors. We have to address the other areas that we tend to forget. Eye care, hearing, oral health. Rehabilitation and disability services are key. And then, of course, being able to track how we're achieving impact. We need to address health information systems. One of our biggest challenges with NCDs is we don't even know because our systems are not able to actually track. So data collection, analysis, and reporting. Communicable diseases, we've done a very good job in putting up systems. But NCDs, major gaps. Monitoring capacity and performance of countries. And then with regards to tracking the magnitude of risk factors, because that's also important. So doing the WHO stepwise approach for risk factor surveillance, NCD risk factor surveys, looking at mental health, substance abuse and surveillance, suicide surveillance are key areas. Looking at oral health. So looking at the whole spectrum of NCDs and make sure that we know we can track the risk factors. And then with regards to health systems, focusing on national and regional health observatory databases. We have started in many countries, but there are still major gaps. And of course, also school health policies and practices. The challenges, apologies. I'll just quickly highlight some of the challenges of the system. Next slide, please. So if we look, there are three areas where we need to focus on. We have to focus on the primary health care level because that's where the biggest gap is. Up to now, we have tended to look at NCDs as a luxury, NCDs as services that should be provided at the specialized level. But there's no way we will be able to address this massive burden that we have by focusing at that level. So we have to go to the primary health care level. And so if we look at the community, just highlighting some of the key things, awareness is key. Access to prevention, early diagnosis needs to happen. But unfortunately, we have major gaps there. High levels of unawareness. Most people don't even know they have diabetes. They don't know that they actually are hypertensive. Very poor access to prevention, access to medicines. If we look at the PHC level, we need to make sure that there are drugs there, there are protocols. We need to make sure that mechanisms are there for people to be referred. We need to make sure that there are skilled human resources there. And when we look at the gaps, most of those areas have massive gaps. And when we look at the first level of referral, very similar issue, because that's where diagnosis should be happening. the initial management, the mentorship and supervision of the primary healthcare levels, the referral to the higher levels, the management. And when you look at the gaps, we have major gaps in all those areas. So we do still have major challenges with regards to provision of essential care for NCDs in many of our countries. Next slide, please. I think I will now highlight some of the proposed strategies on how we can strengthen the health system by integrating NCDs into universal health coverage. And so when we're talking of universal health coverage, it's also the bedrock of universal health coverage is primary health care. I won't go into details about UHC, but PHC is the bedrock. And NCDs are therefore key in us achieving UHC, because it's very clear if that's where the burden is, and we are trying to move towards universal health coverage. Unless we address where the burden is, we are really not going anywhere with regards to UHC. And therefore, we have to integrate NCDs into primary health care and then UHC in general. And the integration of those services will need to make sure that the management and delivery is available, the whole continuum of care, from promotion, disease prevention, diagnosis, treatment, right through to rehabilitation and palliative care. And I loved the presentation on palliative care. That palliative care is not end-of-life care. But I won't go into the details. But it's really important to make sure that we have the whole spectrum of care. And when we're talking of integration, we're talking of functional integration, which would mean ensuring that we're integrating how things are financed. We know our biggest challenge at the moment is resources for NCDs are very limited. Most donors are very keen to support other areas, but NCDs is an area we're struggling to get funding. So we have to find ways of integrating the financing, human resources, technical capacity. You go to the primary healthcare level, the nurse, and we heard about the criticalness of training and having the nurses, because in general, our capacity, HR capacity at all the levels, including among the doctors for NCDs, is quite weak. So we have to look at all those areas, information management, marketing, all those areas. We need to integrate across the functional areas. And then we also need to integrate across the clinical dimension. Coordination of patient care across the system's different functions is important across the activities and across the operating units. And the integration has to be both horizontal, okay, so across the same level, but also vertical, so that patients are able to access services at the different level. Once they need referral from the primary health care, there needs to be an integrated system to ensure that they can access care at the higher level if they need it. Next slide, please. And then I'll present the PHC operational framework for integration. So in this slide, on the left side, it's showing the PHC approach. In the middle, it's showing some of the critical pillars, the PHC levers. And then on the right side, it's showing the results. So we need to integrate health services with an emphasis on PHC and essential public health functions. Is the first piece. We need to make sure that the people in the communities are empowered. They need to engage themselves. They need to be educated. They need to know how to make decisions, including self-care. And then we need to make sure that we have multi-sectoral, or use a multi-sectoral approach with multi-sectoral policies and actions. And the levers are in two groups, so at the policy, at the strategic level, and at the operational level. So the political commitment and leadership is key, governance and policy frameworks, resource allocation, and then engaging with communities and other stakeholders. All those are critical. And then across the health systems pillar, which I won't go into detail with, includes models of care, workforce, infrastructure, medicines. We heard a lot about the medicines earlier on. Engagement with the private sector, among others. So there are many components there, but they are all aligned to the health systems pillar. If we do this, then we will be able to improve access, utilization, and quality, which we know at the moment are major issues. We will be able to improve participation, health literacy, and care-seeking behavior of our people and our communities, and we'll be able to also then improve the determinants of health. This is the only way that we'll be able to start moving towards or make good progress towards universal health coverage. Then we will be able to make progress towards the Sustainable Development Goal 3. And then we'll be able to move towards health for all. Next slide, please. So this slide just highlights also how we can specifically do the integration. So we need to integrate between the different diseases. So one of our biggest challenges currently is we're very vertical, isn't it? Between the NCD diseases themselves. We need to integrate by linking communicable disease, non-communicable disease, sexual reproductive health. It's a key part. And finally, we need to integrate around the people-centered approach, which is a system-based approach. Next slide, please. And we need to use a stepwise approach. Make sure we address the policy issues, we address the package, the benefit package. Make sure that along the health system pillars, we address all those components, the medicines, workforce, and the others I've highlighted, and then make sure we have delivered services. And then at the bottom is communities, and then making sure we have multi-sectoral collaboration. Next slide, please. This slide I won't go into. It's just highlighting some of the tools that are available that we can help us. Next slide, please. Again, this slide is just summarizing. I won't go into, but it's just looking at the different pillars. If you can go back. If you can go back, I just want to highlight one point. So it's looking at the different pillars and giving the details on what we need to do. For example, on service delivery, I'll just highlight a few things. Make sure that at the primary health care, we have comprehensive, continuous, coordinated, people-centered, and family and community-oriented care, among other things that I won't go into. Next slide, please. So this slide is just showing the progress that the countries are making. So WHO has developed a strategy on integrating essential NCDs into PHC. We have progress that countries are making. So for example, we have 23 countries that are implementing the WHO PEN interventions. And we have 8 countries that are now scaling it up at primary health care. So we're making progress, but 23 is very small. 8, which are already moving to PHC, is very small. Next slide, please. And then the next slide is now talking about the PEN Plus approach. So we also need to address severe NCDs in this slide, and that needs to be done at primary level. So countries have also started implementing the PEN Plus approach so that we can also address severe NCDs. So this slide is just showing some of the draft implementation guidance that WHO is developing, ensuring that all the components are being addressed. Next slide, please. And then this slide is just now about the take-home messages. So WHO has looked at the progress that we're making in the different areas, including NCDs. And for us to be able to recover, renew, and have readiness following the shock that we had with COVID-19, WHO has identified 5 priorities. One of those priorities is focusing on supporting a radical orientation of health systems towards PHC as the foundation of universal health coverage. And WHO is pushing for us to have a paradigm shift within the health systems so that we maximize the impact of NCD programs and services. And the 3 points that I'll close with are we need to transition from addressing NCDs and other programs vertically and move towards integrated disease delivery. Secondly, to move from a clinical approach for NCD services to a public health approach. We saw how effective that was with communicable diseases, and we need to move to an integrated public health approach. And then finally, to move from action where we expect that NCDs will be handled by the health sector to where we use a broad-based, coordinated, and intersectoral whole of society approach, where all sectors have to come in. The health sector cannot do it, both in prevention and even in care in dealing with NCDs. We need everybody to have their hand to the plow, including the communities and other sectors. Thank you very much. MC, really appreciate the opportunity.
Round of applause to him, please. And I want you to be the unique one because this is an afternoon session. Could you please rise up and celebrate him? You know what I'm trying to do? Just clap as you're rising up. Thank you, sir, as you walk away. That was unique. That was unique. Please wake up your neighbors. You're clapping. I saw some people were going somewhere. You can stretch a bit. It is allowed. You can stretch. You can stretch. That was a unique one. You know what I'm doing? Stretch up, please. Before I invite my colleagues, stretch up, stretch up. And you can, you know, they talked about mental illness. Can I just hear you laugh a bit if you're happy with what we're talking about? You can laugh a bit. You're welcome to the NCD conference. You may be seated and hand over to my colleague. Thank you.
So whenever you think things are going wrong with your mental health, just have a laughter. She just gave you medicine for free. So thank you very much, Dr. Brian Chirombo. That was really important. The strategies are really awesome. And actually the recommendations are very wonderful. We are not going to take much more of our time. We are going to invite another speaker who is very interesting. He's going to tell us about the challenges and innovative so he's going to tell us about challenges and innovative testing of in the universal health coverage for NCDs. And our speaker is going to be online. This is none other than Dr. Andrea Fejil, who is the CEO and co-founder at the Health Finance Institute. I hope I mentioned it very well. Hear us and you can go on. Thank you. That's very, very, very interesting. I think pulling all the strings, all the levers together, pulling from all sides, from the finance perspective, from the policy perspective, from the civil society perspective, I think that's the way to go. And that's what most of the speakers here kept on talking about, the multi-sectoral approach to the fight against NCDs. I think we are very much in good hands with these presentations that are happening here. I'm not going to take much of the time. I'm going to call on the moderator who's going to take us through the next session. And this is none other than pharmacist Alphonse Barushimana, who is the executive director at the NCD Alliance Rwanda. Round of applause as he comes forward. Some energy, Alphonse, as you come in. I know someone with a lot of energy. Over to you.
Thank you so much, MC. I will try to match your energy as MCs. I want to take the session very quick, try to help me and the panelists. As he has said, I'm called Alphonse Barushima and I executive director of Rwanda NCD Alliance. I think taking more break and being active is not bad. Can you please get up a little bit? Just a quick. As African, you know what called jujuja. So, and I need what I say, you do, you say it, you repeat, and you do it. It's one thing. We say it. Hands up, please. Ajujuja. Thank you so much. You want one more? You want one more? Thank you. Hands up. Legs together. Butt out. Chest out. Ajujuja. Thank you so much. Thank you so much. So, thank you so much for the opportunity. Let me welcome my panelists, but we want to recognize the keynote speech from Dr. Andrea. And I want to say that I'll be having 3 panelists, but also have one who will be participating online. And the topic that we are going to have now is related to health financing, health taxation, and also taxation for an health commodity. And nothing, all the things that, and the program initiative, all the people have been saying here cannot be done without finance. Please pay attention. This is a very interesting topic. And the best panelists I'm having today, they are going to give the best solution that can help us to be financially for the NCD program. A round of applause when I'm calling Lablam Musa from Ghana NCD Alliance to step forward, please. I want to call Mr. Spencer Bujingo. Yes, you have a seat. One to next. My second panelist is called Spencer Bujingo. He's lawyer specialist in East African NCD Alliance. I want to call upon El Nami, who is the head of the program in Global Health Advocacy Incubator. Please step forward. So I want to recognize that you have one panelist who will be participating online. Technical team will let me know if Martin Muchangi from Amlef is available online and can participate. I hope Dr. Andrea, are you still on? If you can just say something that you are still on, it would be appreciated. So since we are now having someone else online, I want to be where, dear panelists, I want to say the audience have told me they trust our panel discussion is going to be quick. Let us not disappoint them. Again, we are going to talk about the finance. Let us hit on the points and we get out to look for finance. First thing, I have 1 minute per each for just introduction. And I want to start with person who is next to me for being safe on the microphone issue.
Yeah, thank you so much. My name is Sailnami Mungure. I work with the Global Advocacy Incubator. I coordinates cardiovascular health program in the region, where we do the campaign, advocacy campaign on the industrial transfers as elimination campaign in the region. Thank you.
Thank you very much. My name is Abujengo Spencer. I'm a lawyer based here in Kigali. And like Barushman has said, I have a background in NCD laws, related laws. And I've done some work on taxation laws. I've also done some work on preventing NCD through tobacco control. So I think or two, I was talking about also how we can get funding from unhealthy products like alcoholic beverages. So my world is I'm a lawyer, and I've been supporting the teams that have been working on NCD. Thank you so much.
Yes, good day. So the name is Labran Musa from Ghana, West Africa. And I work as the national coordinator for the Ghana Non-Communicable Disease Alliance. And I also double as the executive director of programs for the Vision for Authentic Development. I also serve as the board member of Movendi International. Thank you.
Now you see the biggest persons I'm having on the stage. So now you can even expect much. So we'll start one question with a person who had a keynote speech. I hope she will be able to intervene. Dr. Andrea has presented a lot of things related to how we can have financial program and having secure more money for all the program we're implementing. But still, when you look at UN recommendation, they are saying for low and middle income country to reach the target 2030 of reducing premature death by 130 by 2030, we need at least Minister of Health of each country, in low and middle income country, to allocate at least 20% of health budget. But when you look at the current status now, the country, most of the country are spending 1% of their health budget. So I would ask Dr. Andrea, who is also presenting online, what does it mean to Africa? And the proposed solution cost effective when you outweigh the investment and return? That the question should be bouncing back on it. And starting with the people that I'm sitting with, now Ghana is now leading by example in terms of doing taxation on unhealthy commodities. Those are sweetened beverages, alcohol, and different products. But when it comes to taxation, we want to see what are the partners involved, how does that model work, who pays and who benefits. Please, audience, follow if the tax that you are paying, we are the one benefit or not. The floor is yours, LeBlanc.
Great. Thank you very much, Alphonse. And I'm great to be here. Let me say that indeed, and we've heard a lot, today. But of course, if I'll start by saying that indeed, the problems that we've all heard from this morning to today, indeed, is as a result of not another thing, but things that we have actually neglected. Here I'm talking about health-harming commodities or industry products that are creating this problem that we are facing. Because if you are told that 41 million people die annually from non-communicable diseases, and we also told that if nothing or if stringent measures are not put in place, 52 million people would die by 2030. And yet you're not seeing, in fact, I'm not seeing any intervention whatsoever as far as issues of, how to reduce practically, the burden on NCD. In fact, for me, as a person sitting here, I'm not seeing so much of that, especially in that part of the world. I'm saying this because, you see, when I came to Kigali, for instance, as I drove through the streets, I see billboards of, alcoholic beverages, sugar-sweetened beverages. Well, I've not seen anything on tobacco, but I don't know whether it is there yet. But I know largely we've succeeded in regulating tobacco, because of the framework convention tobacco control. But I think that there's a lot that we need to do as Africans. Because if a product is killing us, Surprisingly, since morning, I've not heard much about how to regulate the industry. How do you come up with, policies, regulation that will regulate the industry that is creating the problem that we are facing today in this our world? In fact, we know the solution. The solution have been provided to us. The WHO have come out with the safer package. Nice provision, including taxation, which we'll be talking about today. And I'm happy that we have a lawyer here who specializes in taxation. But of course, when you speak about taxation, many people are like, including the industry. In fact, the industry have actually, brainwashed many people to the extent that once you talk about taxation, they're like, okay, so when you increase taxes, are you trying to take them out of business? And this is what they're also propagating all this while. The moment you talk about taxation, then the industry is at arm with government, with policymakers, with decision makers, with all of our parliamentarians. They want to say, how do we ensure that those proven policy interventions do not work? It has happened in my country, and I know it has happened in many countries. That's why over the years, we've not been able to have a successful regulation of the alcohol industry and sugar sweetened beverages in our part of the world. We only hear of countries like Mexico that's doing so well when it comes to sugar sweetened beverages taxation. And then we also have Thailand and also the Philippines that are done so well in terms of investing in taxation and channeling the money into the universal health coverage of their countries. So for me, I think that there are so many best practices that as a region or as a continent we can actually emulate. And indeed, the industry has said, and they continue to say that the market is choked in that part of the world. So where's the new market? The new market is Africa and low and middle income countries. So they are here and they know that when they come here, they are easily able to manipulate their way through the funding political parties. In fact, these are all on records on what they do to get through to what they want. So eventually you have government, speaking of all the good things, but eventually when it gets to government, it's become practical very difficult to have regulation that will regulate the alcohol industry. So for me, I think that one of the best measures to finance our health sector is one of health taxi. That, in fact, is one of the untapped area. So let us give it a try. Let us give it a try. Countries begin to look at taxation as a means to financing our health sector.
Thank you so much, Lablam. You are sorry to cut you, but we have promised to keep on time. That point, you bounce back on it later. And thank you I want to start where you have stopped already, talking about how those larger company or enterprise. I want to come back to Mr. Spencer. How safe the region is in terms of law, and Lablam have already highlighted. That's when we are also doing awareness and education. Sometimes we compromise with some large companies that are advertising unhealthy commodity. And those unhealthy commodities, they are actually having a large amount of money. They have capacity of doing awareness and even increasing those long message. How safe are we in terms of law in the region?
Yes, thank you so much, Alphonse. I have done some work in East Africa on laws on the area of universal health coverage. We were looking at East Africa mostly. When we were drafting some laws in the area of tobacco control, we looked at laws in West Africa, we looked at Senegal and other countries. But when you talk about safety, how safe we are with laws, I can tell you we have some laws that are inadequate. Meaning we still need some laws, we still need that advocacy, we still need policies geared towards health financing, NCD control programs, and others. But you know that laws ride on a horse we call political willingness. So once you have the political will, then you get the laws to be passed. The parliament will pass the laws, and then you will have laws enforced. Now that will be another area. Yesterday we were talking about how to harness the few available resources. And these are laws that need to be in place to make sure that what we have is harnessed, is protected. And we don't stop at calling on availability of resources, mobilizing resources, but we end up throwing the funds that have been collected into that pit hole that we don't know where it goes, where they go. So that's what I think we need to look at laws, whether policies or implementation programs that ensure that the few available resources that are collected by countries, they don't end up in the pockets of one or two individuals, and then you end up going back to the drawing board of trying to get more funds, yet you are not protecting your funds. And that's why I like some of the programs available, especially in this country, whereby the zero tolerance for corruption and many others, all these audits and all these accountabilities. So these are the laws that we need to ensure that they're in place to make sure that the few available resources are protected and harnessed. And when you talk about universal health coverage, you're talking about funds that go into healthcare, but now we need to follow up and make sure that do we get value for money? Do we get funds back? Do we get results and services back to the community so that when the laws come in, the people have to fear laws at the end of the day?
Thank you so much. Thank you so much for that. I hope the audiences understand that we need to make sure that the general population and the government are bold enough on the commitments for the protection of our population. Technical team, could you please confirm if Martin is now on? And if he's not, we have to move on. I would bring that topic to the audience, please. I will need someone to step in and say something about it. He was about to share experience about air pollution and NCDs, and I want to bring that topic as related to urbanization. Now we are in a city, and what the urbanization is in one of contributing factor on social environmental factor. When it comes to that, you know that result of migration from the rural area to the cities. Now in the middle and income country, most of the people, or all countries, they are looked to be having 60% of their entire population living in the city by 2030. And by that, you know, higher like overpopulation, like low traffic density, that's where there is a small space for physical activity and even poor quality of air. So that's another issue. That's what I want to bring to you on how, where do you think a low and middle income country, particularly Africa, can invest, which is what is the best concern that we can step in to make sure that we are having health and economic protection and also promoting health lifestyle instead of sedentary life. That's concern to the public. I know one of you will respond to me on that question because the speaker for that is not there, but we need to address it. And I will ask him to see if I remain with 5 minutes to stand up so that I can see it. Then I come to the next panelist about transfer taxation. What are you doing in a regional level? What can we take as outcome and learning that we can share the audience?
Yeah, thank you so much. First, I will want to pick it from why are we talking of the taxation in the considered and health product? The first reason, is to discourage the consumption of that product. Not merely making money, not merely for the state to make money. No, the first reason is to help discourage the consumption of the considered and health food product by the general community. Second, it's a kind of benefiting both sides. Also, so when we are discouraging the government, then the government is making some money out of it. So I just wanted to say that we need first to put that, in that understanding. Second, there are issues related to financing, which I'll speak later on. But for now, allow me to share a little bit about what we are doing as global advocacy incubators in the region. For the benefits of who are not aware about the organization, Global Advocacy Incubators is based in US, Washington, DC, and we work around public health. So the program that we have in East Africa is related to the elimination of trans fats acid from the food products, in line with WHO recommendation that industrial produced trans fat acid should be limited to 2% in the food product. So we have our grantees who are working in Kenya, Tanzania, and Uganda, and the objective is at the end of the day, we have a regulatory framework at the regional level that limits trans fats in the food product.
Yeah, thank you so much for that. I hope you understand they are in the whole region of East Africa. One intervention from the audience on that topic. While we are closing, just we can receive one for engagement. No one from audience. Is Dr. Andrea still on, Serge, to respond to my question? If she's not, thank you. No one from the audience. Lablam, we are having, each and everyone are having 30 seconds to close and give take-home message. All the audience have seen that we are having different package that we can even stay in contact and chat. So, but Lablam, I want to touch a little bit on alcohol while you are closing up on your take-home message. And how do you see, where are we now in terms of alcohol consumption, reduction, and regulation in Africa? And where do you think we are heading to? Just in 1 minute.
Yeah, so thank you very much. I think the time is wholly inadequate, but let me say that indeed, we are not making much progress as far as alcohol issues and sugar beverages is concerned in Africa. What I would say is that we have to learn from each other, because I know there's a lot of best practices that Kenya, Uganda can all learn from Ghana, and I think we can also learn from from other parts of the world. So, for instance, I can say that in Ghana have restricted advertisements ban on our screen, which most countries have not been able to do. So, for instance, you can advertise alcoholic beverages from 6 a.m. to 8 p.m. So you cannot advertise alcoholic beverages, And then also we have also banned, celebrities and one of the personalities from featuring in alcohol adverts. And you know what celebrities can do when they advertise, products, just so we are able to protect the young ones in the poor from alcoholic beverages. And I'm saying that we've not made progress because, even at the RCM, the regional committee meeting held in Togo some few months ago, to alcohol and sugar-sweetened beverages was nowhere on the agenda. So it means that there's a need for us to continue to raise the issue with our members of parliament, with our Ministry of Health and Finance, to begin to prioritize and know that indeed it is not all about curative, but it's all about prevention, and prevention. Also taking the industry out of discussion. Thank you very much.
Thank you so much. I see we remain with 1 minute. Let us use it effectively. Mr. Spencer, your take-home message to the audience in 30 seconds.
Thank you so very much. Luckily, we are in the process of developing a legislation on tobacco. No, tobacco is already done. We are looking at alcohol, and it is one area that is looked at to be increased in terms of taxes. So that, like one of the panelists said, not to gain more money by the governments, but to make sure that it's not easy or very cheap for the youths to access to alcohol. So it's looked at, and it's going to be regulated very soon. And we're looking at it. WHO recommends tobacco, alcohol, sugar, salt. So all those are areas that are looked at to be.
Time is ending. I'm sorry to cut you.
Thank you so very much.
Let's hear to the last one about your take-home message in 30 seconds. That's all the time we have.
Yeah. So I will say, as much as we need a regulation to limit trans fats from the food product, as much as we need to tax this product to minimize consumption, but those are not silver bullets. We need also to add more efforts. We need to coordinate our efforts. We need to look at other actions from the producers of those products. For example, receptive market how you both know how much people they are addressing advertising their product, so we need to look at that. But we also need to get the community. We need to empower community, make sure they understand, they understand what are the alternatives of those foods which are considered and health. We also need to make sure they have that behavior of seeking out there.
Thank you so much. Thank you so much. The panelists, a round of applause to thank them. What I get, return on investment is possible when you invest in NCDs. Shaking the hands, please, and thank you so much.
As they're shaking hands, let's celebrate them. A round of applause to them. And a polite reminder, we're at the NCD conference. Ladies and gentlemen, you're really welcome to Rwanda. And we're happy that you're here. Without wasting much time, we'd like to especially thank the sponsors again for making sure that this has happened. Right about now, ladies and gentlemen, online is a very senior person that I cannot talk about what he would like to say. He's going to be sharing about the whole targets for NCDs 2030 in Africa. Hallelujah. And I'd like us to invite Professor Jean Marie. A round of applause for him. If you can hear me, Prof. If you can hear me, Prof, we are ready for you. And everyone is expecting. Prof, if you can hear me, this is your moment. Could you please rise up again? Don't get tired. It's an NCD conference, please. As we wait for Professor, rise up on your feet. Ladies and gentlemen, let's be strong and sharp. Stretch if you can. Wave to me if you can. Call me if you can. Beckon me if you can. Try to kick me if you can. Try, let's see if you to reach here. And how many of you know this song, I Will Make You Fishers of Men? I know I did it last year. So when I fishes, the female sits. When I say men, they stand up. Can we try it? I will make you fishers of men. Men, please sit. Fishers of men. Please. Over to you, Prof. Thank you for making it the NCD regional function. And ladies and gentlemen, right now I would like to invite one strong man to take us through the next session. We have just begun. Are you happy to progress? We came here for a purpose and we need to accomplish it. You're very welcome. Somebody signaling to me that they would like to see me stand here. Please celebrate us. Celebrate us, the MCs. It's not easy standing in front here, but we want to thank you so much for the privilege and the opportunity. I'd like to invite one strong man, Mr. Makumi David, to take over the next session. Please celebrate him as he walks in. Thank you, sir.
Good afternoon. Are you still with me or with us? So I don't want to say I have the misfortune of doing the last session. I'm very fortunate to do the last session because I've been awake and alert just to make sure that I don't miss on anything. This session is going to focus on strategies for health system strengthening and integration of NCDs and into UHC. You know, we are all as healthy as our health systems, isn't it? We are as healthy as our health systems. So we have a number of very, very experienced speakers. I'll not read all their bios because that would be a session on its own. But they have extensive experience in their areas. They are high top-notch expertise in the areas of public health, public policy, academia, and they all have medical background. So these are people who are top of the areas of expertise, so we are very fortunate to have them. I'm told the first speaker, Dr. Jean, is going to present to us online. If the technical team can get that going. Okay. And the presenters who are physically here, Dr. Evariste Ntaganda, I think is here. If Dr. Frederick Katera is here, Dr. Brian Quizera. If you are here, please find your way to the podium so that once we call you to present, you are right here. So if you are in the audience, just find your way. And let's just give them an encouragement as they come. Thank you very much. Dr. Evariste Ntaganda, Dr. Frederick Katera, and we also have someone coming from MSF. If we have a representative, from MSF, make yourself known to us. Okay, you can come over. Please do come over. Yes, I want to believe that is not Beatrice Deuri because Beatrice Deuri is known to me. Purity. So just find a comfortable seat for yourself. Yeah, so if the online presenter is ready, we are going to go to that. If not, I'll just call Dr. Evariste. Dr. Evariste, the online presenter is ready. That is Dr. G. Buchaman. If you can hear us, just get yourself ready because we have exactly 5.5 minutes for this presentation, so that the audience can have a chance to ask questions. So Dr. Jean, we are ready. You can get started at this point in time. Welcome.
companies together. So the goal really in 2015, 2017 is 2027, sorry, 2025 to 2027 is to see expansion of Pen Plus in the countries that are currently implementing it in East and Southern Africa. There's also another additional 8 countries in West Africa that are now conducting situation analyses and that will be ready to initiate Pen Plus programs there. Then there's obviously great demand from a larger number of countries in the Afro region. So we think that we're going to see, we're hoping that we'll see a real breakthrough in NCD care as a result of this initiative. And thank you all for the opportunity to talk about it here. Over to the moderator.
Let's is that me? Yeah, let's appreciate once more and acknowledge that excellent presentation. Yeah, thank you very much, Professor. In Uganda, we're going to give you some 5 minutes so that we have enough time for the audience to ask a couple of questions. I would like to request the audience, please, for this session, we have to ask questions. Okay, if we are to earn our break later in our tea. So prepare 1 or 2 questions from that end, the middle, and that end. Just put down your questions. Let's have the slides, Dr. Evariste, to pigie makofi tafadhali. The slides.
Thank you very much. I will try to go with time. So these are some of the pictures I put there for you to show you how we should really go to the community, because my presentation is talking about interventions in the community. Next, so you can see, sorry, before that, you can see you have lung diseases, have heart diseases. You can see those pictures of the heart that are somehow swollen, others the vessels are blocked. You can see diabetic foot. You can see somebody with legs swollen because of heart failure. You can see somebody with breast with some kind of tumors. So those things are in our community, and that's why when I'm just presenting, giving figures is enough, but also showing the realities of other aspects. So when you're going to teach somewhere like in the community, remember to tell those people that those things are there. Next. So there's nothing other than we do as pertains to the community. These are some of the things: healthy eating, no smoking, don't drink and drive, physical activity, taking health foods in quality and in quantity, please. You would think that you are taking good food, but when it comes into quantity, then it's also a problem. So we have what we call ministerial instruction. We are basing on ministerial instruction, talking about community checkup and health strategic plan, then NCDs campaign that we are doing in the community. Next. So those are some of the things they are doing, but for specifically, this is a research that was conducted in the community. Next. You can read high rates of and diagnosis. So next. I'm just trying to quick. So these are some of the literature. You can see that cardiovascular disease are the leading cause of morbidity. We can know 80% of all cardiovascular diseases, death occur in low and middle income countries. So they are likely to increase up to 23 million. Next. I'm trying to rush such that we. So those are some of the literature we got. We have a prevalence of hypertension, which is 15.9 from the STEP survey of 2013, and 16.8 the report due to get out soon to be reported. So we had objective of exploring the predictors of hypertension and their preferences. Next, please. So it was a cross-section study. We used what we call HBM, health brief method. We did screening in one of the districts which is called the Kirehe district. So we worked with the local authorities. We also had health centers helping under the coordination of Rwanda Biomedical Center. Next, please. So the study was conducted in 8 sectors of Kirehe district. For those who don't know Rwanda, Kirehe district is in eastern province of Rwanda. It has that population, so 90% of them are farmers. Next. Next, please. So data collection, we can learn to do this quickly because we did this normal procedure. Next. So that is the part of data collection and the procedures. Next. So data was captured by this is also method of data collection. I want to go to the results quickly, such that. So you say the mean age was around 46. So the population they were targeting was between 18 and 98. So the females were more. Majority of them had history of alcohol taking. 34% had history of smoking. Then 14% were current smoker, and 19.2% had stopped smoking. Next. So of 4,284 participants, 21% had elevated blood pressure. When we are screening the community, we don't say hypertension. We say raised blood pressure. So when the participants, when the clients reach the facilities, that's when they can confirm that somebody has hypertension. So 82% had hypertension, but they did not know that they had hypertension. Next. So I just want to show that when I'm talking number of participants, according to the group, age and the age group and blood pressure, so basically you can find that the high blood pressure is more predominant in the aged group. Next, 3%. So that was hypertension in BMI. So still all whether they are not obese, where they are not having high blood pressure, all the categories were found with hypertension, as you can see, 17, 18, and 15. I'm trying to rush, sorry, I will give you presentations. Next, for those who want. Next, please. So that was due to, high blood pressure with the blood glucose. So we found that 163 participants had high blood glucose also. Next. So elevated blood pressure increased with age. That was the literature tells it. So age, like we had 33% among aged people of 65 and above. So the smoking, alcohol, and abdominal obesity were the most related to hypertension, that population. So the highlights of newly diagnosed elevated blood pressure and the poor control among rural population shows us that the epidemiologic transition for hypertension, we should increase awareness. We should also do regular screening and also do more studies to understand why people are having high numbers of, high blood pressure. So I think I was doing a race. Yes.
Thank you, Dr. Taganda from the Rwanda Biomedical Center. Good job. Well done. Excellent study. You almost won the race. Almost. Yes. And next, I said we need to prepare questions. Folks, we need to prepare questions. Get a question or two for Dr. Ntaganda about this study and the community interventions that they were having. You can see everyone nodding, so there are enough questions for you. I'll ask Dr. Brian Kwizera. Yeah, he's over there. We are not going in any particular order. Dr. Brian is from ICAP Global Health. He's are going to tell us about integration of NCDs and HIV services. I think he wanted his slide hanging up there, so he can keep to the script.
It's okay. Thank you. Thank you so much. I'll take just 3 minutes. So I'll try to make a case for people living with HIV.
Yeah, this is important. Let's pay attention. We're talking about NCDs and HIV, and you know HIV is where the money is. So we need to pay attention to what Dr. Kwizera is talking about.
It's shifting to NCDs actually. So HIV is under control. So the prevalence of HIV in Rwanda is 3%, and it has been so for the past 10 years. So why do we need integration of NCD for HIV services? So it's a program that I work for, which is the network of 21 countries that deals with coverage and quality of government for people living with HIV. The main focus is improving DSD models. What we do here is differentiated delivery. So it's a clear-setted approach that simplifies and adapts HIV services across the cascade. And in the past years, we are seeing that the growing population is people that are aging with HIV. So that has been contributed to increasing the age for people living HIV. We are expecting in 2025 to have around 35% of our population being above 50 years that have HIV. And so that's why we need NCD in HIV. So how do we do this then? So from a health system perspective, chronic diseases share key characteristics with HIV. And also the recipient of care perspective, there is integrated services that could improve uptake, adherence, and retention in HIV and NCDs. So what lessons can we learn from HIV that we can adopt in NCD? So one could be like performance-based financing. The other one is removal of user fees for people with living with HIV because they have a double burden of disease. We know that HIV services are free. So this could be done, like for instance, for preferential financing in case of removing costs for NCD drugs and cancer drugs. So we also felt like the whole group was talking about tax shifting. So we need to tax shift the role of other providers to the HIV provider, like a nurse in this instance, or peers or expert clients that can serve these NCD clients in the community. So what we're talking about here is kind of adopting rapid, simple, and standardized diagnostics testing and appropriate appointment and reminder systems and community follow-ups within the community. So we could simply, with fewer resources, train our HIV providers to follow up NCD clients within the community. And we're talking about patients with double burden of disease, HIV and NCD. And this is a fact because we know that there is direct effect of HIV infection on cardiovascular system. And it is also affects some drugs affect the lipids and glucose within a patient living with HIV. So without further ado, we should focus on the how of doing this, and this can be seen through differentiated service delivery model, which addresses the who, what, how, and when to give these services. And with bringing down the cost, we could also let our clients have multi-month prescription for NCD drugs. In this case, it will reduce transport costs and allow them to have these services within their community. Thank you so much.
Thank you. Thank you. We need to appreciate that. Prepare 1 or 2 questions about HIV because, and keep in mind, you know, people tend to be very territorial. So you tell us whether HIV, people working in HIV are willing to integrate or they want to protect their territory, isn't it? Yeah, people can be territorial, so you tell us some of the challenges likely to happen. I have Kajuju from MSF. If I was a big donor partner with big dollars, and you want to make a 3 minutes case, yeah? Kajuju. A 3 minutes a case for community engagement and integration of NCDs in primary healthcare. What would you tell me? if you want my wallet open with big dollars.
Yes, I would love
In 3 minutes, elevator pitch.
Thank you very much. My name is Purity Kajuju. I work with MSF together with Beatrice. Beatrice Wave. Yes, her name is on the program that I'm presenting. 5 years working with MSF in NCDs in Embu County. And the program was to decentralize NCD care into primary health care. What was happening then is that all NCD patients, or most of the NCD patients, were stuck in Embu level 5, the highest level in the highest hospital in the county. And the physicians and the specialists spent all their time just doing prescriptions for these patients. So MSF sat and asked, what better can be done? Can stable NCD patients be managed at the primary health care level? And the answer was yes. So MSF stepped into Embu County through the support of the National Department, National Division of NCD Division, and the Embu County Department of Health, and we were able to implement a decentralization program through which we offered mentorship for healthcare workers, nurses, clinical officers, and community health volunteers. We enrolled 7,000 patients, and these were not new patients. Only 11% of these were new enrollments within that period. These are patients who were already receiving care at the high-level hospital. And in mentorship, we concluded mentorship for around 63 healthcare workers, and the community health volunteers included. But then MSF was winding up, and there was a deep cry from these patients. And the question was, what then do we do? Because patients were realizing or had realized that MSF was also supporting the county to supply their NCD drugs and to give commodities for NCD lab reagents and other equipment that were required. So patients gave a call, and we had, and the call was that let there be continuity in NCD drug supply. Discussions with the county and the national governments, we know that in Kenya, the budget was not sufficient. It's still not sufficient for the government to be able to supply NCD drugs. So all these 7,000 plus patients were put into support groups. The support groups were registered, and together they came to register community-based organizations. Now we have 2 patient-led community-based organizations in Embu County that are championing the NCD service provision in the county. NCD drug supply still remains a major challenge. So what MSF helped the CBOs to do is to establish community revolving pharmacies as a stopgap measure and a support for the MOH system, that when NCD drugs are not available at the MOH facility, patients can access quality and price-controlled NCD drugs at the community revolving pharmacy, but at a cost. And that's a challenge, because when a cost is impended, we know that not everybody will be able to access the drugs. So we are still working with the CBOs to continue advocacy, to continue reporting what the patient is encountering at the community level, so that the county, the national government can take up, the CSOs, the NGOs can take up in the support for NCD drug and commodity supply for NCD patients. Thank you.
Good job, MSF. Excellent model. I'm sure there are many people who would like to hear about the community pharmacies and how that is working. So prepare questions for her. She's not off the hook. Dr. Katera, we are on your case now from PIH Rwanda, Partners in Health. Please make a case for, you're talking about task shifting, is it? Yes. Now make a case to this big donor.
I was waiting for the 3 million to give to her before I make the case.
I'm not convinced yet. The audience got to be convinced. Build a case for task shifting. Thank you.
I work for Partners in Health. And as an NGO, our heartbeat is really about reaching, understanding. the village for Christmas. So I'm hoping that you can see where the difference is. Right now, we are using a bus for sightseeing. So things are changing. Maybe not so much for the best, but there you are. So we reach many underserved populations. We also work with government. We don't work individually. So we work in partnership with government. We believe it's the most sustainable way to invest in healthcare systems. So with regard to NCDs, we have almost 3 portfolios collectively. The first one is an oncology program seated pretty much in one district hospital, and it provides the entire continuum of care services from diagnostics to treatment to palliative care and all that. So I guess that's another conversation for another day. And then 2, we have another neglected group, which is really children with disabilities, those who are born with different functional endocrine or labor-based complications who are also not attended to. So we have 2 clinics of about 1,600 children who are followed up in that clinic. And then maybe the more relevant part is the integrated NCD care. Part of it is actually what Jean Beckman was referring to. Partners in Health, again in partnership with government, catalyzed the first NCD programs really in district hospitals, and then was able to push that down to health centers. And at health center level, where the issue of task shifting comes in, we were able to provide a lot of training for nurses who are in their training, but also in their experience, don't have a lot of care and competences to manage diabetes, hypertension, chronic obstructive diseases like asthma, but also heart failure. And we've been able to do that pretty much for all the clinics in our 3 districts. The model has been captured and improved by Ministry of Health and now has been scaled up in the entire country. So it's a privilege to work within that partnership model that allows you to, on one hand, catalyze, on the second hand, keep improving and make things better, but also be able to design a program that is scalable to the entire country. Yeah.
Excellent. Good summary, the way we like it. Can we appreciate him? I have mics here. I would like to get some help. Let's get a question from that corner, from that side, a question from the middle, a question from that. We are all part of this. Please tell us which speaker you direct your question to, or if it's a generic question, any of the speakers, I'm sure we'll be happy. It is our turn to talk. Thank you. There's a question here. Is that a question over there? Oh, I didn't see a hand. Okay. And if, yeah, there is another question over there. It is our turn to engage the panel. So we have a revolving mic. Yes, Prof.
Yeah, mine is actually not a question, it's just a comment and a point of information. There is a project which was conducted by PEPFAR and Fogarty International from around 2013 to 2018 called the PEPFAR NCD project. It involved about 6 African countries on data pertaining to integration of HIV care, of NCD care into the PEPFAR platform for HIV. We held a symposium during AIDS 2018 in Amsterdam and also took up a special supplement issue in the AIDS journal. There are about 15 papers there indicating the mechanism of integration and the evidence that exists for integratability of HIV and NCDs and policy implications for the same. And since then, we had very high-level meetings with the leaders of PEPFAR in Washington, and PEPFAR actually commissioned all PEPFAR HIV programs to incorporate NCD care, and the mechanisms of incorporation and the policy requirements were all dealt with at that level. It then behoved the governments, especially in sub-Saharan Africa, to implement those policies within the CCCs. And that is indeed happening. If you looked at the care cards, things changed. So the question that remains is one that I heard being addressed there, and that is the contribution of our governments to provide medicines and technologies for NCD care within the HIV programs. So that was just a point of information. So we are talking about scaling and mainstreaming of NCD care into the PEPFAR platform. Thank you.
Excellent. Thank you for that comment. Do you have any reaction? You're on the same boat. There was a question or two on that side. So if we can get a mic over there. I've not had a question from these guys, so they haven't earned their evening tea and coffee. So we need a question from this direction. Yes.
David, mine is like a comment. Why are we keep on saying that excessive alcohol consumption, according to recent research done in Britain, there is no safe level of alcohol. So this is a very misleading. And in Ethiopia, we have argued with the Ministry of Health, and we have stopped that. There is no safe level of alcohol consumption. Please stop talking about excessive and distorted ideas about alcohol. There is no safe level consumption of alcohol. Thank you.
Thank you. Thank you very much. That's an important reminder, or is it a gentle reminder to all of us in this space? Yes, there's a question or a comment? Yes, sure. Proceed.
Thank you. My question is to Beatrice from MSF. I'm very intrigued by the initiatives that you had for the patients and for the way you are able to organize them into those two patient groups. So I'm curious to know whether you have thought about community insurance and whether there's a way by which perhaps you have encouraged those people either to get an HIF or to get into one of the more affordable commercial insurance policies so that as a group they could be taken up, think of a cooperative in that sort of manner, and that would make it easier perhaps to access medicines and care.
Yeah.
Thank you. Yes, that is a very good question. And yes, it is something that we are considering. The patients themselves are already discussing and forming ways of engaging with NHIF to be able to register either as individuals or as groups. As at now, at the community revolving pharmacy, NHIF is not useful or has not started being used yet, but then that's a plan for 2023. Thank you. And for the formation of the CBOs and the CRPs, we have some pamphlets that will give so that you can get more information on the processes. I'm sure Beatrice, my colleague, will be able to distribute those.
Excellent. Thank you. Do we have a question on this end? A comment is also welcome. And some thoughts, some reflections from this direction. Yes, there is one over there. Yeah, thank you.
Thank you so much. My question goes to Beatrice. I just want to know how on the revolving pharmacies, how those members are able to manage the drugs at the community level. Thank you.
I can go now. Thank you very much. So what is happening right now is we have two community revolving pharmacies in Embu County, and MSF gave a seat to these. MSF, together with the County Department of Health, have given technical assistance to develop systems for the community-based organizations, the group of patients, to manage the CRPs. We have a tri-party agreement, an agreement between MSF, MOH, and the CBOs. MOH is giving space and licenses and is offering human resource, the pharmacists who will then dispense the drugs and ensure that all the protocols around dispensing of drugs are followed. The CBO officials will come to the CRP every day and ensure that NCD patients are well guided on how to purchase the drugs. We do bank payments, no cash collections at the CRP, just to keep it safe. And MSF continues to offer technical assistance to see that the CBOs grow in their capacities to continue being able to manage the CRPs and grow the CBOs to be independent bodies.
Thank you. Thank you. There's another question right here. We're just coming to a close. We're almost coming to a close, so I don't want to lock anyone out. You have many questions pent up from the evening, isn't it? Yeah.
So I would like to say thank you to all the panelists for their brilliant presentation. My question goes to Dr. Frederick. So you said partners in health work hand in hand with the government. Now, what I would like to know is what are the difficulties your institution faces with governments noting that most of the time our governments have policies, but they don't usually implement them. And in quotes, sometimes our governments are corrupt, and it becomes a little bit difficult in actually implementing some of these policies. So I really want to know the difficulties you face on a daily basis.
You've asked the question for all of us.
Yeah. I am choosing not to make an accident in front of the police. The government is here. I'm not going to criticize them in their presence. But and again, this is not just being overly optimistic. We generally have a very progressive government. There's a lot of direction in what government wants to do. There's a lot of collaboration within the implementing entities at Rwanda Biomedical Center. I don't think it's per se a government problem. It's more really the complexities of working in any big institution. So those are not necessarily the problems. It's trying to find out what works within that setting and how to improve things within a collaborative space. To be honest, also, we do have a culture of many NGOs or foreign funded agents wanting to run vertical programs that are not integrated for reasons of control and other factors. But ultimately, the end game is that government is responsible for providing healthcare services. And to the degree that you strengthen and work with them, to that degree, you introduce something that is sustainable. So I would probably look at it more in that light rather than saying there are problems per se. But let's be honest also, sometimes we get funds, and I don't know, I can't speak for every NGO, and you have both an implementation structure and a timeline to deliver. And so you do have probably pressure from the funder. But the reality is that at the end of the day, where the rubber meets the road is service delivery. And whatever magic bullet you have, you still need to have a magic gun. You need to have a delivery mechanism. And it's all about having conversations and having a broader understanding of all the key players, designing a process map of how you deliver what you want to do, and having the wisdom to execute it within a partnership model. There's no other way you can go around it. I'm very sure that in all our homes, we could blame each other, but ultimately, the better way to go is to go as a unit in a home. So I don't know whether that helps.
Thank you. Thank you very much. If there is one last question, I will allow it. Otherwise, we are just coming to a close. Just a very quick one. I don't want the audience to think that this moderator didn't have questions of his own. So I was just being clever to get you guys to ask questions for me. But Dr. Ntaganda, I hope I'm pronouncing it right. Yes. What were you finding reflective of the entire Rwanda? Do you think what you found in that particular district, does it reflect Rwanda?
Yeah, the results, my results were from a particular district, but when you compare with the national step survey, the figures are almost close. So it reflects what is happening over in Rwanda. Thank you.
Thank you. And Dr. Kwizera. Yes, I had one question at the beginning, just in one sentence. We've talked integration at all high levels and all that, but in practice, on the ground, in Kenya, we say kwa ground, on the ground, do you experience sort of protectionism, people protecting their turf? We are HIV, you are NCDs, you are this, you are that. At the end of the day, human beings behave weirdly and they may feel threatened. Have you experienced that? Yeah? Have you experienced that?
Thank you.
Just in one sentence.
From the current data that we have, the stigma index, current stigma index is low compared to the previous years. So there is a kind of, when you shift care to the hands of these people that live with HIV, at a certain point, you reach the point that you can address stigma in itself. So when we talk about expert clients and peer, these are support mechanisms that support actually people living HIV to accept their illness and adhere to their medication. So with in coming years, with living with HIV for a long time, people have come to accept that. And then it has somehow addressed the issue of stigma, but we know that it still exists. What I wanted to extend was to show that the progress that has been made in HIV could be made in NCD and CADA. Thank you.
Excellent, excellent. Me, I'm the moderator who demands my panel to be appreciated. Let's just do that. Let's appreciate these guys. Great team, good stuff. Excellent, excellent presentations, excellent knowledge, and you're just the top in your areas. Really do appreciate these guys. I also tend to demand to be appreciated. I don't think I was that bad. So thank you very much, ladies and gentlemen. I think this is the end of the session. These guys are available. You can interact with them out over coffee, just get more details about what they are doing in their communities. Good job. Keep it going. Thank you very much.
Let's celebrate them as they come down. As they're coming down, I'd like you to please rise up before we make the final announcements.
For sure. This is very interesting. Very, very interesting. And a big round of applause to you yourselves. It's been a nice audience since morning up this time, and you're still very alert. And I like how you have been very engaging in this very last session.
Godfrey, one more thing. Please stand up. There's one thing that they need to do before you make the final announcements.
Okay.
On your feet, ladies and gentlemen, please. You see, when I have the microphone at the moment, you know, you have to help me. Could you please hold the hand of your neighbor? I think we are all safe.
Hold your neighbor's hand.
And this is very critical, the cameramen. I'd like you, ladies and gentlemen, if you can hear me, just say, I can hear you. Could you please tell your neighbor, we can make it together?
We can make it together.
Could you say that loudly, please? We can make it together. And the people outside did not hear. Can we confirm to them that we have pledged to do it together one more time?
We can make it together.
And finally, after saying it, you will lift up your hand as a pledge. We can make it together. One more time.
We can make it together.
Thank you so much. My name is Caroline, all the way from Uganda, and I'm privileged to MC with my colleague.
Geoffrey Baingana from Rwanda. We are exceedingly humbled and profoundly honored to have been your hosts. Allow me to make only two announcements.
You may be seated as he's making the announcement.
Be seated. This is the last one. For your information, the paper I'm holding has something written on. So what is written here is telling me 10 minutes left. So I will not go past that, but I'll use less than 10. First of all, Kigali tour. You want to move on top of Kigali, make a registration. It's only 20 USDs. The paper is circulating. The paper is circulating, but if you can't see it around, you register there. Please, we are starting off at 6. We shall be moving. So there is tea, there is coffee outside here. So we shall be networking as others are registering. So as that one is happening, please, we have very interesting exhibitions happening in the booth. Make sure you go there. Another thing is that tomorrow is the day. We have very interesting sessions tomorrow. Let's be here. 8:30 is the time the first speaker is going to be on the podium. You are all very wonderful. I love you so much. I wish I can be the MC even tomorrow. I'm going to give something to the organizers so that I'm the MC tomorrow. But thank you very much. I thank my co-MC for today, and I thank the audience for being very wonderful. Thank you very much. Have a nice evening.